Hey guys, what's up? This is Stephanie. Welcome back to my channel. So in the video today, I'm going to be doing an endocrinology review for your PANCE exam. So it's going to be for your Physician Assistant National Certification exam. Hopefully this video is helpful for you, for those of you who are currently in PA school or are PA student and are studying for your PANCE exam, have graduated PA school or studying for your PANCE exam, or for those of you who are in PA school as a PA student and are studying for your didactic exams. Hopefully this video is helpful for you. Real quick, a little bit about me. I am currently a practicing physician assistant in the ICU, critical care medicine, and I took my exam in December of 2020. I am going to be going over my notes that I had for my PANCE exam. I passed my PANCE exam the first time I took it. I took my PANCE about 4 weeks after I graduated from PA school, and I'll be using the notes that I used to help me pass my PANCE. So hopefully this video is helpful. I have a link below also where I have the playlist for all the other subjects that are covered on the PANCE exam. Hopefully they're helpful for you. And these are meant for you to listen while you're working out, driving, for those of you who are auditory listeners. I think the big advice I can give to you is going to be repetition. So it's really important that you repeat this information as much as you can, whether it's through flashcards, whether it's through audio. That's what I did. I listened to a lot of audio podcasts, which I'll add the links below also. I did a lot of flashcards also, and then just making sure that you quiz yourself daily, because passive reading without you absorbing the information will not help you pass the PANCE. It's important that you're constantly quizzing yourself and testing yourself to see what you know and what you don't know. Okay, the other thing I do want to say is that I'll be looking down at my phone a lot, and that's because I have the majority of the notes on my phone and or on the notebook, so I'll be looking down a lot. So the first one we want to go into is going to be your pituitary disorders. So pituitary disorders. If I repeat something over and over again, that's because it's very highly tested, and I will let you know. And like I said, I like to repeat things over and over again because repetition is a key for you to actually ensure that you have that information ingrained in your brain. So I'll be repeating things a lot. So the first one's going to be your pituitary adenoma. This is going to be a benign tumor in the hormone-producing cells of the pituitary gland. The origin is usually going to be your anterior pituitary. So we think about, for example, what hormones are released in the anterior pituitary. This is something that's very commonly tested, so they're going to test you what hormone is released from your anterior and your posterior pituitary. So we think about our anterior pituitary, we think about our growth hormone, ACTH, prolactin or TSH, thyroid stimulating hormone, our LH, luteinizing hormone, and then our FSH, follicular stimulating hormone, or follicle stimulating hormone. So once again, growth hormone or GH, ACTH, prolactin, TSH, LH, and FSH. So make sure you know this is going to be for your anterior pituitary. So etiology. The most common pituitary adenomas you're going to see is going to be prolactinomas. I currently work in the neurovascular ICU. By far, that's going to be the most common ones I've seen. So prolactinomas, they are about 50% of the pituitary adenomas you're going to see. Other types can be non-secreting pituitary adenomas, which are usually just benign, growth hormone secreting pituitary adenomas, ACTH secreting pituitary adenomas. We think about Cushing's disease, right, in these cases. Microadenoma pituitary adenomas, and this is usually going to be less than 10 millimeters. Versus your macroadenoma, which is going to be larger than 10 millimeters. And actually, your microadenomas are more commonly found than your macroadenomas. So how is this patient going to present? If it's causing mass effect on the brain, usually they'll have symptoms of hypopituitarism. So they'll have anterior hormone deficiencies. These are going to be most commonly than posterior symptoms, headache, visual disturbances, field deficits, and this is usually due to compression of the optic chiasm, which makes sense, right? So it's really important that you check your fields or just a neuro exam in these patients. Cranial nerve dysfunction, and then endocrine hyperfunction. This is usually due if they have a tumor that's functional and it's secreting hormones. Diagnosis, usually these patients present with incidental findings. It's going to be a patient that got a scan and then they noticed that it was a mass and they wanted to make sure that it was not malignant, so they scanned them and make sure that they investigated even further. So study of choice is going to be an MRI. Usually you'll see a cellular mass and or lesion, You can also do endocrine studies, so you're going to look at the prolactin, right? Growth hormone, ACTH, TSH, FSH, and LH. So once again, pituitary adenomas, it's going to be a benign tumor in the hormone-producing cells of the pituitary gland. Origin is usually going to be your anterior pituitary. What hormones are going to be released by the anterior pituitary? We think about growth hormone, right? ACTH, prolactin, TSH, LH, and FSH. So since we said prolactinoma is like one of the most common type of pituitary adenomas, let's go into it. So prolactinomas, these are going to be benign tumors or adenomas that secrete what? Just like it sounds, prolactinoma, excess prolactin. So prolactin is usually stimulated by your TRH and is inhibited by dopamine, okay? So once again, it is stimulated by your TRH and is inhibited by dopamine. So that's something important that you have to know. So what is your TRH? It's going to be your thyrotropin releasing hormone. Once again, your thyrotropin releasing hormone. So with these patients, the most common cause is going to be hyperprolactinemia. So they have increased amounts of prolactin. Also, some of the causes of this can be pregnancy, primary hypothyroidism, certain drugs like dopamine antagonists, and estrogen also can be the etiologies for these prolactinomas. And with these patients, you're going to be presenting with the symptoms of galactorrhea and ovulatory amenorrhea, especially if it's a woman, right? And this is due to inhibition of the GnRH that causes decreased luteinizing hormone and follicular stimulating hormone that causes decreased estrogen, infertility, headaches. Why? Because it's compressing the meninges, and then they're going to have that bitemporal hymenopsia, and this is due to what? Why? This is because you have compression of the optic chiasm. And then in men, these patients are going to be presenting with gynecomastia, erectile dysfunction, and decreased libido, okay? So with these patients, how are you going to diagnose them? So the first thing you want to do is you want to look at the prolactin levels. Usually the patients that we have in the ICU will work together with neurosurgery because sometimes they have to go and get these removed, especially if they're pressing on the optic chiasm and it's causing them to have these visual defects. But meanwhile, we also involve endocrine, and endocrine, one thing that they do is that they trend prolactin levels on these patients. So your initial study for these patients is going to be a serum prolactin level, and it's going to be very, very elevated. You also want to make sure, since a lot of these patients, if they're women, they present with amenorrhea, so they present with having a history saying that they don't have any menses. You want to make sure that you rule out pregnancy, right? So you want to rule out other causes before you say it's a prolactinoma. So rule out pregnancy, exogenous estrogens, right? Are they taking any type of estrogen use? Hypothyroidism, dopamine 2 antagonists, right? What is their history? Do they have a history of any type of psychiatric disorder where they're taking medications that can interfere with their dopamine? Do they have a history of end-stage renal disease, cirrhosis? You want to make sure that you rule out all these things. But of course, the most accurate test is going to be your MRI. You want to make sure that you look at the tumor. And what you're going to see usually on your MRI is going to be a snowman appearance. It's going to literally look like a snowman. And the difference between your micro prolactinomas and your macro, like we discussed, the micro is going to be less than 10 millimeters. This is something that's very commonly tested, so it's really important that you know this. So micro, less than 10 millimeters. Macro is going to be more than 10 millimeters. And usually with your macro, most of these cause mass effects. And then usually your micro ones are very common to cause functional effects. So we think about mass effects like the compression, right, on the brain that can cause all these neurological changes. Treatment for this, the best initial one is going to be your dopamine agonist. So a lot of these patients that we have in the hospital, we have them on cabergoline and or bromocriptine. The common one that I see is cabergoline for us. And these usually shrink the tumor. And we do this usually in patients that are, once again, are waiting to go to the operating room with neurosurgery. If it's symptomatic and it's very large, like we say, these ones that are causing mass effect, then usually they'll get a transsphenoidal surgery. And those are really interesting, the transsphenoidal surgeries, because just like it sounds, they go through the sphenoid. And a lot of these patients that we take care of, you have to make sure that they can't blow their nose or cause any pressure. So that's really, really interesting. So once again, prolactinomas, very, very commonly tested, so make sure that you know these, right? So prolactinomas, we think about the symptoms that they're going to present. If it's a woman, amenorrhea. They're going to be presenting with, just in general, men and women, galactorrhea, loss of libido, vaginal dryness if it's a woman, dyspareunia. They can also present with osteoporosis. And with these patients, they're going to be presenting with the bitemporal hemanopsia, right? That's where they have loss of temporal field visions. They're going to be presenting with headaches, diplopia. Why? Because you're having that compression, especially if it's a mass one, a large one, like greater than 10 millimeters. They're going to be compressing on the ocular motor nerve. They can also have pituitary apoplexia, cerebrospinal fluid rhinorrhea with these patients. And like I said, with these patients, the best initial test is going to be your serum prolactin, which is going to be elevated, but your most accurate one is going to be your MRI. You're going to see that stenoma appearance, and make sure that you know the difference between a micro and macroadenoma. So micro is going to be less than 10 millimeters, macro is going to be greater than 10 millimeters, and usually these already cause mass effects. Treatment is going to be your dopamine agonist, and that's going to be the best initial one. So we think about cabergoline and/or bromocriptine. This is going to shrink the tumor. And then, of course, if it's symptomatic with these patients, we want to do transsphenoidal surgery. Next one's going to be acromegaly. This is going to be due to an excess secretion of somatotrophs. So we think about growth hormone and insulin growth factor 1, right? Acromegaly, usually with these patients, you have acromegaly and you have also gigantism. Make sure you know the difference between both of these because this is very commonly tested. So acromegaly is going to be usually in your older patients, right? And this occurs after the plates fuse, versus gigantism. This is going to be used in your children. It's going to be before the plates fuse. So the pathophysiology of acromegaly is that there's an overproduction of growth hormones. So you have an abnormality in the insulin growth factor 1 that comes from the liver. So what this causes is it causes an overstimulation of cell growth and proliferation. So you start having these symptoms with these patients. The most common cause or etiology is going to be a growth hormone secreting pituitary adenoma, right? And usually symptoms is going to be insidious. So it's going to be a patient that presents that they start having these coarsened facial features, right? They start having this flat nose, enlarged hands or feet, or jaw also. It's going to be a patient where their ring finger doesn't fit them anymore. That's usually what I read in the question stem. They're going to have these soft, doughy, sweaty handshakes due to enlarged sweat glands. They have history of carpal tunnel, which makes sense because you're having enlargement of everything and it's causing pressure on that median nerve. Increase in shoe size, like we said, ring size, glove size. You can also have visceromegaly, which means enlarged kidney, enlarged thyroid, bitemporal hemanopsia, especially because once again, that mass is just causing pressure on your nerves. You'll have cardiac symptoms, which is one of the most common causes of why these patients die early, right? We think about Andre the Giant, who had acromegaly. So cardiac symptoms, congestive heart failure, cardiac hypertrophy. So it's really important with these patients that you suspect if they have acromegaly. You want to make sure that you order an echocardiogram, okay? So make sure you don't miss that on a question stem. You want to order a transthoracic echocardiogram just to make sure that you rule out any type of cardiac condition, which was interesting. The reason why Andre the Giant died from was cardiac cause. Dermatology, they'll have acanthosis nigricans, which makes sense because these patients are extremely diabetic. GI-wise, they can have colon polyps, colon cancer, so it's really important that you order colonoscopy for these patients. And then endocrine-wise, you're going to have insulin resistance, impaired glucose intolerance, and just very overt diabetes mellitus. And that's why they have the acanthosis nigricans. So once again, this is very commonly tested, so make sure you know this, right? It's going to be that patient that just has these coarsened features. It's like, oh, my wife says that my ring doesn't fit anymore, my shoes don't fit anymore, my gloves don't fit anymore. You want to make sure that you order an echocardiogram, transthoracic echocardiogram, right, to make sure you rule out any type of cardiac disorder, cardiac hypertrophy, congestive heart failure. Make sure that you look at their glucose levels. These patients are usually very diabetic. They'll have the acanthosis nigricans, which is like the velvety darkening in the back of the neck. These patients are very prone for getting colon cancer, having colon polyps. You want to make sure that you screen them for colorectal cancer, so you're going to get a colonoscopy for these patients. So diagnosis, the best initial diagnosis, if it asks you that, is you're going to get your insulin growth factor 1 levels, or your somatometin C. You're going to see increased insulin growth factor 1 levels. but the study of choice is going to be an MRI. Once again, you're going to see a pituitary mass. So make sure that you read the question. If it asks you what's the best next step, right, or the best initial insulin growth factors, if it asks you what's the most accurate test, then we're thinking about, or the study of choice, the MRI, because that's where you're going to see the mass. And then also most accurate tests, if it also asks you that, you want to make sure you do an oral glucose tolerance test with the serum growth hormone in 2 hours. And usually the growth hormone is normally suppressed by the glucose. If it's not, then you're thinking about your acromegaly. So once again, best initial insulin growth factor level 1, most accurate, your oral glucose tolerance test with the serum growth hormone. The study of choice is going to be an MRI. So make sure you know that. Study of choice, MRI, most accurate oral glucose tolerance test. First line treatment for this is going to be surgical removal. So you're going to do transsphenoidal resection once again for these patients. If growth hormone continues to be elevated, then you're going to make sure that you give them drugs that are going to suppress it. So you do some somatostatin analogs, things like octreotide. This is going to inhibit growth hormone secretion. You can also do cabergoline or pegvisomant. So cabergoline is a dopamine agonist. Pegvisomant is a growth hormone receptor antagonist. So once again, acromegaly, very highly tested, right? You have acromegaly and gigantism. Gigantism is going to be in children. It occurs before the plates fuse. Acromegaly is going to be in older patients. It occurs after the plates fuse. And most common cause is going to be a growth hormone secreting pituitary adenoma. Make sure that you order an echocardiogram, colonoscopy for these patients, glucose levels, because these patients are prone for getting CHF, cardiac hypertrophy, colorectal cancer, colon polyps, right? Acanthosis nigricans. Diagnosis, best initial is going to be your insulin growth factor level 1, somatostatin C. Study of choice is going to be your MRI. You're going to see a pituitary mass. And then your most accurate one is going to be your oral glucose tolerance test. And first line treatment is going to be surgical resection, right? You can also give them medications like octreotide, pegvisomant, and cabergoline. Next one's going to be diabetes insipidus. Oh my gosh, this is something I see so much in the neuro ICU. So diabetes insipidus with these patients is, what is a patho? So usually these patients have decreased ADH or antidiuretic hormone and vasopressin, right? We think about either central or nephrogenic, which we're going to get into a little bit more detail. So once again, they're going to have decreased ADH and vasopressin. And usually these patients are going to have increased volume of dilute urine. So they're going to be urinating a lot, like more than 3 liters a day. And they're going to have decreased urine osmolality. It's going to make the urine more dilute, which makes sense because they're urinating so much. They're going to have increased serum osmolality. So that means that the osmolality of the serum is going to be very, very concentrated. And usually with diabetes insipidus, you want to make sure that you know the difference between central and nephrogenic, because those are going to be the 2 types. So with central, it's going to be the most common type of diabetes insipidus. It's usually due to a decrease in your antidiuretic hormone release. And the reason why I see this so much in the ICU is that it's very commonly found in head trauma. So that's why I see it a lot in the neurovascular ICU. So any type of head trauma, I see it a lot in our subarachnoid patients. So whenever I see a patient that starts urinating so much with these patients, it's really important that I start working them up for diabetes insipidus. So other causes can be neurosurgery, tumors, ischemia, things like Sheehan syndrome. It can also be idiopathic, but by far the most common one you're going to see is head trauma or any type of neurosurgical intervention where they're messing up in the brain. Now, nephrogenic is usually due to resistance to ADH, so the kidneys are just not responding to the ADH, versus central is because you have just decrease in ADH, but the kidneys are kind of like, give me, but nothing's happening, nothing's coming up from the brain. Versus nephrogenic, the kidneys are just like, they're not even responding to the ADH. And this is usually due to kidney disease, also very commonly found in drugs. So make sure that you look through the drugs that the patient's taking. We think about lithium, right? That's one of the big ones. So if it says a patient has a history of any type of psychotic problem or behavior problem, think about maybe lithium or nephrogenic diabetes insipidus. Usually the patient has renal unresponsiveness. They won't be able to concentrate any type of urine with these patients. So how is this patient going to present? Like I said, polyuria, polydipsia. If I have a patient that comes in, had a subarachnoid hemorrhage, got a decompressive hemicraniectomy, right? They were messing around their brain, and then I have a patient that the nurse comes up to me, they're like, they had about like 5 liters of urine output in the past 24 hours. I'm like, what? And that's when I start sending labs to make sure I rule out diabetes insipidus. So polyuria, where they're urinating a lot, polydipsia, where they're drinking a lot of water. They're going to have increased urinary frequency, nocturia, craving for water, cold liquids, dehydration, low blood pressure, fatigue, nausea, confusion. So with these patients, if it's a central diabetes insipidus, right, we're going to get an MRI of the pituitary gland with these patients. If it's a nephrogenic cause with these patients, we're going to do a kidney ultrasound, okay? So once again, treatment's going to be, if it's for central diabetes insipidus, you want to treat the underlying problem. And usually we'll give him DDAVP, right? So we'll give him something like desmopressin and or vasopressin. In the ICU, we give him a lot of desmopressin. This is a synthetic ADH. And this is if it's central, right? Because they have lack of ADH, so you're giving them ADH. So it's going to be a patient that's urinating a lot, polyuria, they're super thirsty, polydipsia, right? Their urine's going to be very, very dilute. Their urine osmolality is going to be also very dilute, but their serum osmolality is going to be concentrated, which makes sense, right? Because they're holding to everything. They're holding onto all the sodium. They're like, oh, I'm holding on to all the sodium. So usually these patients are going to be hypernatremic. So hypernatremic with these patients. All right, if it's a nephrogenic cause, you want to treat the underlying cause or condition, right? If it's a patient that has a kidney disorder, you want to make sure that you treat that kidney disorder. Usually you'll give them diuretics. You can do things like hydrochlorothiazide, right? Amiloride, indomethacin, and sodium restriction. So once again, right, central versus nephrogenic. Central diabetes insipidus is decreased secretion of antidiuretic hormones. So they have very little diuretic hormone versus SIADH, which is syndrome of inappropriate antidiuretic hormone. That means that they have too much antidiuretic hormone. One of my attendings calls it this, which I think is amazing. He says excessive antidiuretic hormone because he says that the brain secretes appropriate amount of antidiuretic hormone and there's never an inappropriate amount. So that's why he disagrees with SIADH. He says it's excessive ADH, which makes sense. So if that's helpful for you, diabetes insipidus is decreased secretion of ADH versus SIADH, or how my attending calls it, excessive ADH, is that you have an increased amount of ADH. So it's going to be the opposite. So central diabetes insipidus, decreased secretion of ADH, right? Usually the ADH is secreted from the pituitary gland for these patients, and causes are going to be idiopathic, head trauma. I was talking about my subarachnoid patients, right? Any type of traumatic brain injury, post-cardiac arrest patients, any type of neurosurgery manipulation. And these patients are going to have a dilute urine, so there's sodium in their urine. It's going to be, or urine sodium, it's going to be very low, but their serum sodium is going to be super high. So they're going to be hypernatremic, right? Hypernatremic, but their urine sodium is going to be low. Same thing for nephrogenic. So this is where the kidney is resistant to ADH. So the brain is working, right? The pituitary gland is releasing the antidiuretic hormone, but the kidneys are just not responding to it. Causes are going to be some of your drugs. Lithium toxicity is going to be the very common one that you're going to get tested on. Any type of renal disease, pregnancy medications, like I said, even hypokalemia for these patients. All right, diabetes insipidus, we said, right? Central, nephrogenic, you're going to have what? Polydipsia, polyuria. These patients are going to be urinating so much. Usually I hear the term, they're peeing like a horse because they're having more than 3 liters of urine per day. Their urine osmolality is going to be decreased, right? So their urine is going to be dilute. Some of the nurses will go up to me and they're like, yeah, their urine is clear, right? Which makes sense. It's dilute. And they're going to be hypernatremic, so their serum osmolality is going to be concentrated and increased. Achondroplasia/dwarfism. So that's going to be the next topic. This is lack of growth hormone. So this is a complete opposite of acromegaly, where you have too much growth hormone. These patients with achondroplasia and or dwarfism have decreased growth hormone, or they have lack of it. So usually these patients have congenital skeletal dysplasia that results in shortened extremities and macrocephaly. Some of the etiologies is usually it's autosomal dominant, and it's a mutation in the fibroblast growth factor. So it's going to be your FGFR3 where there's a mutation in. Usually these patients are asymptomatic. They'll just have macrocephaly, right? Frontal bossing, shortening of arms and legs, more notable especially on the proximal segments, lumbar lordosis, kyphoscoliosis. Treatment is conservative, right? These patients don't need treatment. There's shows about patients that have dwarfism. We just find it very fascinating. Usually it is just preventing any type of complications, since a lot of these patients have complications. So physical therapy for leg bowing. Usually these patients have a normal lifespan. They're normal intelligence, normal reproduction. Okay, next one's going to be your parathyroid disorders. So we finished all your pituitary disorders. Let's go into our parathyroid disorders. So in regards to your parathyroid disorders, the first topic is going to be your hyperparathyroidism. So your hyperparathyroidism. This is an excess in parathyroid hormone production. You have increased PTH, increased calcium, and hypercalcemia. So that's how your labs are going to look. Some of the etiologies, the primary cause, which is the most common cause, right, which is something primary which is occurring at the parathyroid, is usually a parathyroid adenoma. You can also have parathyroid hyperplasia. We think about MEN1 and MEN2A. This is something that's very commonly tested, so make sure you know that, right? MEN1 and MEN2A, parathyroid hyperplasia, familial parathyroid hyperplasia, and then parathyroid cancer. Secondary causes, that means that they're not coming from the parathyroid itself, but from somewhere else. We think about chronic kidney disease, vitamin D deficiency, chronic hypocalcemia, and then tertiary causes, we think about parathyroid hormone independent of blood calcium levels. So that's usually the cause, that it's independent of the calcium levels in the blood. So how is this patient going to present? So the most common symptom is that they're usually asymptomatic. How are you going to see it in your question stem? It's going to be your kidney stones, right? Your osteoporosis. Why? Because you have bone loss due to increased osteoclast activity, pancreatitis, fractures, decreased deep tendon refluxes with these patients, which makes sense, right? Hypercalcemia, decreased tendon refluxes, if you know your symptoms of hypercalcemia. We think about hormones, groans, stones, bones, and psychiatric overtones, if you've ever heard that. I'm a huge fan of osmosis, and osmosis always goes over that. Moans, groans, bones, stones, and psychiatric overtones. So moans, the patient's going to say that they're not feeling well. Groans or have abdominal pain or GERD. Even constipation. Stones, kidney stones, bones, bone pain, and psychiatric overtones are usually depressed. So what's going to be the best initial test for these patients? So you want to make sure you get a serum calcium. You're going to get it twice, right? It can either be increased or normal. So once again, you're going to get a serum calcium level times 2. And you're also going to get a PTH level, which is usually going to be increased. So once again, parathyroid hormone and a serum calcium level is going to be your best initial test. Other things you can get is phosphate, creatinine, vitamin D levels, especially if you're trying to rule out a secondary cause like we discussed of hyperparathyroidism. So if it's a primary cause of hyperparathyroidism, this is where they like to test you, so make sure you know this, is that what you're going to see on your labs is going to be increased calcium and increased parathyroid hormone, which makes sense, right? If it's coming from the parathyroid itself, then you're going to have increased parathyroid and increased calcium. Your phosphate, though, is going to be low. Versus if it's a secondary cause, right? With these patients, you're going to have thyroid toxicosis, Paget's disease, and then the calcium usually is going to be greater than 13 milligrams per deciliter. Treatment for this is usually IV fluids. You can give them loop diuretics. This is going to help lose the calcium, right? Loop diuretics usually cause hypocalcemia. And then treat any type of underlying cause. If it's a if it's a parathyroid adenoma, then it's going to be surgical intervention, right? You can also do a DEXA scan just to make sure everything is normal. So like I said, surgery, you're going to do a parathyroidectomy, since that's the most common cause of primary hyperparathyroidism, is going to be a single parathyroid adenoma. So you'll do a parathyroidectomy, especially if it's a patient that has recurrent kidney stones, right? And make sure that with these patients, if they do have a parathyroidectomy, they have a lot of post-operative hypocalcemia, so you want to make sure that you treat that with IV calcium. And then usually if a patient's asymptomatic and they're surgical candidates, usually with these patients, you want to make sure you, like we said, we can do a surgical intervention for them. If they're not a surgical candidate, then usually we'll do biphosphonates. And then, so patients that are asymptomatic and are surgical candidates, they have to have one of the following. So for a patient to be a surgical candidate for parathyroidectomy, they have to have a reduction in their bone density. So usually we think about our T-score, right? So if our T-score is less than 2.5, negative 2.5, then they are a candidate for a parathyroidectomy, or if they're younger than 50. All right, hypoparathyroidism. This is going to be the opposite, right? You have two lists of parathyroid hormones. So they have decreased parathyroid hormones. So they're going to have decreased calcium. They're going to have hypocalcemia and hyperphosphatemia. So with these patients, the PTH is usually, the PTH normally causes increased calcium and decreases phosphate. But since with these patients, they're going to have decreased parathyroid hormone, and you don't have parathyroid hormone that usually increases your calcium and decreases your phosphate, you're going to add the opposite, right? So these patients are going to have hypocalcemia and hyperphosphatemia versus your hyperparathyroidism. You're going to have increased PTH, increased calcium, but decreased phosphate, right? Because what does a parathyroid hormone like to do? It likes to increase your calcium and trash your phosphate. So etiology of hypoparathyroidism, this is where we have to think once again of our primary causes and our secondary causes. Primary causes are usually idiopathic. Most common one you're going to see is post-surgical, so it's going to be a patient that had a thyroidectomy. By far, that's going to be the most common one, so look for that in the question stem. Patient of a history of they have a history that they had their thyroid removed. Also, other causes can be autoimmune. Secondary causes of hypoparathyroidism is going to be magnesium deficiency, end-stage renal deficiency, end-stage renal disease, vitamin D deficiency. And how is this patient going to present? They're going to have carpal pedal spasms. Usually the symptoms that I think about are going to be symptoms that are associated with hypocalcemia. So they're going to have your carpal pedal spasm, your trousseaux. What is your trousseaux? That's where you do the blood pressure cuff, right? I've never seen it. I've seen only videos of it, but I've never seen it in person. So you're going to do your blood pressure cuff, and usually when they press it, they're going to flex their hand. They're going to have the Shavatsky's sign. This is going to be the facial twitch, and then also oral paresthesias. This is very commonly tested, so make sure you know this. So if you have a patient that presents with hypocalcemia or hypoparathyroidism, look for these symptoms. Look for your trousseaux, right? Blood pressure, cuff, causes flexion of the hand, your Shavatsky's sign, the facial twitch when you tap on it, the face, perioral paresthesias, increased deep tendon reflexes. This is usually symptoms of hypocalcemia. Muscle cramps, paresthesias, usually perioral and or in your fingers, anxiety, tetany, dry skin, and cataracts. So how are you going to diagnose this? You want to do a serum calcium, do a PTH, and a phosphate. Like I said, it's going to be the same thing for hyperparathyroidism and hypoparathyroidism. So we said hyperparathyroidism, your parathyroid hormone is going to be elevated, your calcium is going to be elevated, but your phos is going to be decreased because what does a parathyroid hormone do? It likes to trash your phosphorus. Versus hypoparathyroidism, your calcium is going to be low, your parathyroid hormone is going to be low, and your phos is going to be what? It's going to be high because you don't have parathyroid hormone to kind of like trash your phosphorus. Other things you want to do is you want to get an albumin. Why? Because it's the main carrier of your calcium. Usually in a patient that I have that's hypocalcemic or hypercalcemic in the ICU, they always ask me about my albumin. So make sure you get the albumin. Get your magnesium levels. Usually on EKG, you're going to see QT prolongation, right, with these patients. And like we said, primary hypocalcemia, hyperphosphatemia, decreased PTH. If it's a secondary cause of hypoparathyroidism, they're usually going to have an increased PTH because the parathyroid is working, it's something else is not responding to it. So usually these patients are going to have renal failure or history of vitamin D deficiency. Treatment is, of course, treating the underlying cause, right? If it's a patient that has too much phosphate in their diet, then you want to tell them to decrease the phosphate in their diet. If the patient has symptoms or has a calcium less than 7.8, we want to give them IV calcium gluconate. If the calcium is greater than 7.6, then we want to give them PO calcium carbonate plus a vitamin D supplement like calciferol or ergocalciferol. All right. Next one we're going to go into is hypogonadism. Okay. So hypogonadism is a clinical syndrome that is associated with impaired functional activity of the gonads. Both males and females are affected. So etiology, usually you want to think about primary and secondary. So for primary, it's usually due to insufficient sex steroid production in the gonads. Secondary is due to insufficient gonadotropin releasing hormone or gonadotropin release in the HPA, so the HPA axis. Primary hypogonadism usually is congenital. So usually with primary hypogonadism, we think about Klinefelter syndrome, right? Usually very commonly found in your males. Turner syndrome, which is very commonly found in your females, and then androgen insensitivity. For your secondary hypogonadism, which is usually acquired, it's most common due to pituitary/hypothalamic disorders. We think about things like Kalman syndrome, neoplasms, and any type of eating disorders. So make sure you know the difference between primary and secondary. So once again, primary hypogonadism is usually going to be congenital versus secondary hypogonadism, it's going to be acquired. How is this patient going to present? They're going to have delayed puberty. So you think about the Tanner stages, right? Sexual dysfunction, infertility, erectile dysfunction, decreased libido/fatigue, decreased muscle mass. And females are going to be presenting with amenorrhea, so no menses. And then for Klinefelter, so what did we say Klinefelter was? Was it primary, secondary? So Klinefelter is going to be a primary cause of your hypogonadism, right? Usually it's going to be a boy with gynecomastia and small testicles on your question stem. Turner's, is that primary or secondary hypogonadism? So Turner is going to be your primary hypogonadism. This is going to be a girl that usually has like a very webbed neck, and then they have a very short stature. And then Kalman, how is a patient with Kalman going to present, and what type of hypogonadism is it? Is it primary or secondary? So Kalman is going to be your secondary type of hypogonadism. This patient is going to present with anosmia, absent breast development, uterus, but the uterus is present, and they're also going to have syndactyl also. Syndactyl. So diagnosis is going to be your hormone labs. You want to make sure you get a testosterone level in males and an estrogen levels in females. So usually in males, their testosterone level is going to be decreased, and the estrogen level is going to be decreased in females. So in order to differentiate between a primary and a secondary cause, it's going to be in your labs. So in your primary patients, primary causes of hypogonadism, like we said, this is usually due to gonadal malfunction. So when it's primary, it's due to the main problem, which is going to be your gonads. So primary is going to be your gonads are not working. So with these patients, you're going to do an FSH and LH, which are going to be elevated. And then you're going to do your GnRH, or your gonadotropin releasing hormone, which is going to be elevated also. Secondary causes, usually we think about the gonads are working, but it's going to be something in the pituitary or in the thalamus. So it's going to be hypothalamic or pituitary cause. You're going to get an FSH and LH, and usually these are going to be decreased. And your gonadotropin releasing hormone is going to be decreased. And that's how you tell the difference between a primary and a secondary cause of hypogonadism. Treatment's going to be management of the underlying cause. So if it's a tumor, you want to make sure you resect it, right? You can also do hormone replacement therapy, and this is usually triggers onset of puberty at an appropriate age. Okay, next one's going to be your thyroid disorder. This is something that's very commonly tested, so let's get into this one. So let's think about our first one, which is going to be your hyperthyroidism. So just like it sounds, it's too much thyroid. So we're going to have increased thyroid hormone. Your T3 and T4 are going to be increased also. It's very commonly found in your females, especially between the ages of 20 to 40s. And then also very commonly associated with drugs. So the common one that's very highly tested is going to be what type of cardiac medication. It's going to be amiodarone. So the most common cause of hypothyroidism in general is going to be Graves' disease, right? This is usually an autoimmune disorder that causes antibodies and B cells to stimulate TSH receptors, and this causes overproduction of the thyroid hormone. So in regards to the second most common cause, we think about our toxic multinodular goiters. So this is usually due to an expansion of cells, due to mutation of the TSH receptors. Pituitary adenomas that cause increased TSH. It can also be induced by iodine. So how is this patient going to present? They're usually going to have a goiter, heat intolerance, fatigue, weakness, dyspnea, palpitations, weight loss, amenorrhea, decreased libido, diarrhea, hyperreflexia. So how I memorize this one is that everything's just an increase versus hypothyroidism, everything's decreased. So hyperthyroidism, goiter, heat intolerance, fatigue, weakness, dyspnea, palpitations, weight loss, amenorrhea, decreased libido, diarrhea, hyperreflexia. Symptoms of Graves, since we said the most common cause of hyperthyroidism is going to be Graves, we think about our triad, so it's going to be your exophthalmos, and I've actually seen these in multiple patients. So it's their eyeballs are just really enlarged, or their eyeball sockets. So exophthalmos. The other one's going to be your lid lag, pretibial myxedemia, diffuse goiter. So they're going to have the growth of their thyroid gland. Diagnosis, the best initial test is you want to make sure you get a TSH level, a T3, and a T4 level. So TSH, T3, and T4. Usually your TSH is going to be decreased, but your T4 is going to be elevated, which makes sense, right? Because your thyroid stimulating hormone is kind of saying you don't need me anymore, or so I'm going to be decreased, versus your T4 is just going to be very, very high. And this is usually due to primary hyperthyroidism. Okay. Usually if we think about a toxic multinodular goiter, usually if we get a scan of these patients, usually we'll see a high uptake on your radioiodine uptake test. So on your radioiodine uptake test, what you're going to see is high uptake with diffuse homogeneous radioactive iodine distribution. If you see that, you think about Graves. This is very commonly tested. They're going to show you a picture of it, so make sure you know this. So on your test, you're going to see high uptake with diffuse, which makes sense, right? It's diffuse, it's homogeneous radioactive iodine distribution, that's Graves. In your toxic multinodular goiter, you're going to see high uptake with nodular, which makes sense, right? Because it's nodules. Nodular with radioiodine distribution and multiple patchy areas of accumulation. So first-line treatment for hyperthyroidism is going to be methimazole, PTU, okay, so propyl thiouracil PTU, and or methimazole. The thing that you need to know is that which one you're going to give in what patient. So if the patient's pregnant, you're going to give PTU, especially also if there's a thyroid storm, you're going to give PTU. If not, in every other patient, you're going to do a methimazole. If the patient has severe hyperthyroidism, they're on medications and it's still not getting treated and they have these severe symptoms, and you're going to think about a thyroidectomy. Next one's going to be your thyroid storm. So with these patients, thyroid storm, what are you going to do with these patients? So how is this patient going to present? This is an emergency, okay? Thankfully, I've yet to take care of one of these patients, but they're going to be presenting with severe hypermetabolism. They look fatal, and they can have fatal complications of these symptoms of thyrotoxicosis, of hyperthyroidism, and it's usually going to be due to a precipitating event. So something precipitated, whether it's an infection like a new pneumonia that they had, a trauma, like did they just have a surgery? So usually with these patients, it's going to be two causes: something precipitated it, and or the patient is just not taking their medications for their hyperthyroidism, they've been undiagnosed or poorly treated. So like I said, other causes, which is the common ones you're going to see, is surgery, trauma, infection, iodine overload, amiodarone, also contrast dye, exogenous T3. So how is this patient going to present? So I was actually reading a question stem the other day, which was really interesting. It was not the other day, I remember months ago when I was studying for the PANCE, and it stayed with me. It was basically a woman that wanted to lose weight, so she started taking exogenous T3, and then she presented in a thyroid storm. So that's another way that they can present. So with these patients, how are they going to present? So it's going to be the same symptoms as hyperthyroidism, right? Your fatigue, your diarrhea, your palpitations, but it's going to be exaggerated. So the classic symptoms are going to be hyperthyroidism, fever, tachycardia, arrhythmias, and ultramental status. So they're going to be very agitated and or anxious. Diagnosis is usually clinical. You can get a TSH or free T4. Usually you can't measure the TSH, but the T4 is going to be very, very elevated. They'll have abnormal LFTs. You can get an EKG and you'll see arrhythmias in these patients. Treatment it's going to be ABCs, right? Assess their airway, assess their breathing. Since a lot of these patients are going to be hypoxic, they're going to be very, very hypoxic. They're going to have palpitations. They're going to be dyspneic. Some of these patients you might need to intubate. So administration, how are you going to treat these patients? The first thing you want to do is get their heart rate under control because these patients are very prone for getting arrhythmia. So you want to give them a beta blocker. So you want to control their heart rate. Second thing you want to do is you want to give them PTU and or methimazole, right? And then third line, you want to do iodine and steroids, things like dexamethasone. You can also do plasmapheresis to remove all those antibodies. So once again, hyperthyroidism, the most common cause of just regular hyperthyroidism is going to be Graves' disease, most commonly found in a woman, right? Diagnosis, we're going to do a TSH and then a T3 and T4 level. With these patients, the TSH is going to be down, but their T4 is going to be elevated. Treatment for these patients, first line is going to be methimazole and PTU. Now, if the patient's pregnant, you want to do PTU, right? If it's severe symptoms, then these patients are going to do thyroidectomy. Thyroid storm is an emergency. These patients are usually something precipitated, whether it was an infection, if they're septic, do they have a new pneumonia, even a urinary tract infection, or did they just have surgery, or have they just been undiagnosed, or are they just not complying with their medications, or are they taking in some T3 in some way? With these patients, diagnosis isn't clinical. You can do a TSH, but usually you won't be able to find the TSH level. So usually you'll do a T3 with these patients. You'll do an EKG because these patients are very prone for getting arrhythmias. And then, like we said, the treatment is going to be your ABCs, airway, breathing, circulation. Do you need to intubate them, stabilize the patient, right? Get an EKG. First thing you're going to do is you want to make sure that you manage the arrhythmia. So you want to make sure you place the patient on beta blockers. That's going to be the first line or the first thing. Second thing is you're going to do PTU for these patients. And then third line would be iodine and steroids, and then also plasmapheresis. So next one's going to be your dequervin thyroiditis, also known as subacute thyroiditis. This is going to be a transient, once again, transient inflammation of the thyroid gland that causes release of T3 and T4. So they're going to have increased T3 and T4. This is usually due to an injury of the thyroid follicles. Most common cause is going to be viral, and it's usually preceded by an upper respiratory infection. So read in the question some that the patient had they just recovered from the flu a few days ago. And it's most commonly found in females than in males, most commonly found in adults. And usually a patient will have both a hyperthyroid state and then a hypothyroid state, which makes sense, right? Because it's only transient. So this is how it'll differentiate it from your hyperthyroidism. So symptoms, they're going to be presenting with hyperthyroid symptoms, so they're going to have this enlarged, painful thyroid, jitteriness, weight loss, tachycardia, hair loss, heat intolerance, and then they'll have the hypothyroid symptoms, so weight gain, right? Everything slows down, weakness, pretibial myxedema. So with these patients' diagnosis, you want to make sure, like we said, the stage 1 is going to be your hyperthyroidism, and then they're going to go into euthyroid, and then they can get hypothyroid, and then they'll go back to euthyroid, which is where they recovery. So the gold standard for this is going to be your like we just discussed, a radioactive iodine uptake test for these patients. So once again, radioiodine active uptake test. That's going to be the gold standard. Treatment is usually self-limiting. You don't really have to do anything because we said it's transient. These patients do get better. But you can give them NSAIDs because the thyroid is very, very painful when they get that inflammation of the thyroid gland. So you can give them NSAIDs or aspirin for pain, also beta blockers, and then you can also give them steroid. That's usually second line. Next one's going to be hypothyroidism. This is going to be the complete opposite of hyperthyroidism. This is going to be failure of the thyroid gland to produce sufficient thyroid hormone to meet metabolic demands, most commonly found in elderly, especially females and males. Also in your postpartum patients. The common one we think about is Hashimoto's, right? Hashimoto's hypothyroidism, iodine deficiency, especially in patients that live in third world countries. We think about iodine, so deficiency. So make sure you read that in the question stem if it's a patient that immigrated from somewhere else. It's history of autoimmune disease, family history of thyroid disease. So how is this patient going to present? So it's going to be the opposite of hyperthyroidism. Everything's slower, right? Weight gain, fatigue, weakness, cold intolerance, constipation, delayed deep tendon reflexes, brittle hair and nails, dry skin, lateral eyebrow loss or hair loss, memory impairment or difficulty concentrating, menorrhagia, depression, myalgias, coarse facies, bradycardia, edema, goiter, hypothermia, decreased cardiac output. How I've seen him in the question stem is going to be fatigue, cold intolerance, weight gain, and then I've also seen it in difficulty concentrating and menorrhagia. So look for that in the question stems because sometimes it'll confuse me and I think it's a OB-GYN problem and not a endocrine disorder. So menorrhagia, hair loss, weight loss, and then just like if they have difficulty concentrating or memory impairment, think about also hypothyroidism as your differential diagnosis. So best initial tests, you want to do your TSH, T3, and T4 levels, right? Your thyroid function test. Usually with these patients, the TSH is going to be elevated because the thyroid stimulating hormone is telling the thyroid to work. So it's like, hey, work. I'm like calling you, but you're not picking up. So calling, no one's picking up on the other side. So the TSH is going to be elevated. The T4 is going to be down. And usually if we see an elevated TSH and a T4 that's down, we think about primary hypothyroidism. If the TSH is just low, then we think about hyperthyroid state. If the TSH is high, but you have a normal T4 level, this is subclinical. This is what they really like to test you on, so make sure you look at the labs and the TSHs and T4s. So once again, TSH is high, T4 is low. That's just your classic primary hypothyroidism, right? We said someone's calling, thyroid's not picking up. Now, if the TSH is high and you have a normal T4, then that's subclinical. If your TSH is high and your T4 is also high, then that's secondary hypothyroidism. If your TSH is low and or normal, then and on top of that you have a low T4, then we're thinking about secondary, tertiary, and or sick euthyroid. Treatment just for hypothyroidism in general, your primary is going to be lifelong hormone therapy, so levothyroxine, right? With these patients. And complications of hypothyroidism, if it's a patient that is just undiagnosed or, like we discussed, is not taking their medications, then you can get a myxedema coma. This is where they present with bradycardia, hypothermia, hypotension, and altered mental status. So now that we've discussed myxedema, coma, and crises, why don't we go into a little bit more detail? So myxedema, crisis, and coma is going to be an extreme form of hypothyroidism. So remember how we said that the thyroid storm is an extreme form of hyperthyroidism? Well, your myxedema coma is going to be your extreme form of hypothyroidism, very high mortality. Causes of this, it's very rare. It's most commonly found in your older women, especially if they have long-standing hypothyroidism. And usually it's going to be a patient that comes in during the winter or cold weather, and they're presenting with these severe forms of hypothyroidism. So make sure you look for that in the question stem, so winter or cold weather. Symptoms, it's going to be usually classic. They're going to have decreased mentation and hypothermia, hypoventilation, hypoglycemia, hypotension, bradycardia. So like we discussed, it's going to be the complete opposite of the extreme form of hyperthyroidism, which is going to be your thyroid storm. So everything's going to be down. Diagnosis is going to be clinical. You want to make sure you look at the patient, right? Feel their skin, physical exam. You'll get their TSH and T4. Their TSH is going to be high. Their T4 is going to be low. Now, in regards to treatment, you want to make sure that with these patients, if you have a very highly suspicion that the patient is in myxedema coma, you start treating these patients before you get any type of confirmation from the lab. So you still send the labs, but before waiting on the labs, it's important that you treat these patients. You want to make sure that you go once again through your ABCs, airway, breathing, circulation. Do they need to be intubated? Is their mental status so severely depressed, or are they so hypoxic that they're not able to protect their airway? Do you need to intubate these patients? Or are they unresponsive? And then, of course, treat any type of underlying cause that might be causing the myxedema coma or crisis. And usually it's supportive care. Usually these patients are going to give them IV levothyroxine and hydrocortisone also. And usually your hydrocortisone is going to be in stress doses. All right, guys, so just a little bit about T3. What does it do? So T3, it speeds up cells' basal metabolic rate, right? And so what happens is that T3, another thing that it does, it causes increased cardiac output. it stimulates bone reabsorption, it activates the sympathetic nervous system, which makes sense, right? If you have an elevated T3 and T4, especially when you're a hyperthyroid patient, you're going to have all these symptoms because that's the mechanism of action. So once again, make sure that you know these. The commonly tested ones is going to be hypothyroidism, hyperthyroidism, mixed edema coma, and thyroid storm. So make sure you know how to diagnose these and how to treat these. So next one's going to be your adrenal disorders. This is something I see a lot in the ICU. So first one's going to be your primary adrenal insufficiency and or your Addison's disease. So the pathophysiology is just failure of the adrenal cortex that leads to a deficiency of aldosterone, cortisol, and androgens, right? Usually we think about the zona fasciculata. It's a cool name. So with these patients, what you're going to see is that usually what does aldosterone do? So normally aldosterone will decrease potassium, it'll increase sodium, and it'll increase your blood volume and pressure. Androgens, they produce DHEA, and this is a precursor of testosterone production in both men and women. So the most common cause, now since we've kind of gone through the pathophysiology of primary adrenal insufficiency, is going to be autoimmune adrenalitis. So you're going to have an increase in your ACTH hormone. Other causes can be infectious. Tuberculosis by far is the most common one. So if you have a patient that's an immigrant that's coming from a third world country, think about tuberculosis, right? Other causes can be an adrenal hemorrhage, infiltration of the adrenals. So how is this patient going to present? They're going to have decreased aldosterone, right? Because they have adrenal insufficiency. They're going to have hypotension, dizziness upon standing. So they're going to have orthostatic symptoms. Their cortisol is going to be decreased. And they're going to be presenting with weight loss, anorexia, fatigue, lethargy, depression, muscle aches, GI upset, so nausea, vomiting, diarrhea, sugar and salt cravings. Their androgens are going to be decreased, so they're going to have loss of libido, loss of axillary and pubic hair, but their ACTH is going to be increased. So their ACTH is going to cause hyperpigmentation, and that's a big one. That's one I can guarantee you're going to come up on your test. So make sure that you know that primary adrenal insufficiency is associated with increased ACTH, decreased androgens, and decreased cortisol. So increased ACTH is going to cause your hyperpigmentation. And usually it's going to be in areas that are not very commonly susceptible to sunlight, right? So look for hyperpigmentation. And usually with these patients, the diagnosis, the best initial test is going to be serum cortisol, and it's going to be an AM level serum cortisol. And the confirmatory test is going to be your concentropin stimulation test. So this is where you give synthetic ACTH. You can also do a CT of the adrenal glands, and then you can also do a pituitary MRI just to rule out any type of mass. And then with these patients, in regards to their labs, you're going to be presenting with hyperkalemia, and this is something that you really need to know, and this is how you'll be able to tell the difference between primary adrenal insufficiency or hypoaldosteronism and then hyperaldosteronism. So with primary adrenal insufficiency, they have less aldosteronism, right? So they have hypoaldosteronism. They're going to have hyperkalemia, hyponatremia, and metabolic acidosis. And they're going to have hypoglycemia. Why? Because you have less cortisol. Treatment for these patients is going to be with both glucocorticoid and mineralocorticoid replacement. So you're going to give them hydrocortisone and fludrocortisone. So the hydrocortisone is going to help, and usually with these patients you'll increase the dose, especially if they have any type of stressors, right? If they're going to surgery or anything that's going to stress your body. And then fludrocortisone also you're going to give them. This prevents hyperkalemia, sodium loss, and volume depletion. So once again, primary adrenal insufficiency, most common cause is going to be autoimmune. We think about Addison's disease. Interestingly, President Kennedy was known for having Addison's disease. And with these patients, they're going to be presenting with a decreased aldosterone, decreased cortisol, decreased androgens, but an increased ACTH, which makes sense, right? ACTH is calling, hey, pick up, no one's answering. Adrenocorticotropic hormone is going to be elevated, right? They're calling, pick up, no one's picking up. Adrenal glands are not picking up. So decreased aldosterone, decreased cortisol, decreased androgens. Diagnosis, we said an AM cortisol level is going to be the most and the best initial one, right? Confirmatory test is going to be your concentropin stimulation test. This is where you give them ACTH, it's synthetic. If you want to rule out a pituitary mass, and or an adrenal gland masses. We're going to do a CT of the adrenals and pituitary. With these patients, they're going to be presenting with hyperkalemia, right? Hyponatremia and metabolic acidosis. They're also going to have less cortisol, so they're going to be hypoglycemic, and treatment's going to be with hydrocortisone and fludrocortisone, remembering that if a patient's going to go through something that's going to stress them like surgery or they're having some type of infection, give them an increased dose of hydrocortisone during any type of stressors. Next one's going to be acute adrenal insufficiency. This is also known as your Edisonian crisis. This is going to be acute severe glucocorticoid deficiency, and this is an emergency because this is very fatal. Usually these patients get admitted to the ICU. Etiology, major stressor, like I said, any type of surgery or an infection that pushed this patient that had already Addison's disease over the edge, and now they're in Addisonian crisis. Also, if a patient has a sudden discontinuation of the glucocorticoids and they weren't weaned off, just completely discontinued off of them, very commonly. Also, I see this a lot in our ICU patients. They get very adrenally insufficient, so a lot of these patients, we put them on steroids also. We'll get cortisol, we'll actually get random cortisol levels on them. But usually studies have been shown in ICU patients that cortisol levels are not very reliant because they're already elevated, since a lot of these patients are like they have pneumonia or they're post-op and they already are, their body's stressed, so it's going to be elevated, so it's not a good marker in ICU patients. But regardless, these patients usually will start them on both hydrocortisone and fludrocortisone. But I just wanted to give you an example. Hopefully that will help you stick it in your brain. So like I said, major stressors like injuries, surgeries, infections, burns. We think about our Waterhouse-Friderichsen syndrome, and I apologize if I butchered that. So with these patients, they usually have a sudden increase in blood pressure, rupture of adrenal vessels, ischemia, and gland failure. This one isn't commonly tested. I've seen it in practice questions, but just to make sure you know about it. Waterhouse-Friderichsen syndrome, sudden increase in blood pressure, rupture of adrenal vessels, ischemia, and gland failure. So this patient is going to be presenting with sudden fever, abdominal pain, vomiting and diarrhea, dehydration, hypotension. Usually they'll be in shock, like syncope and cardiovascular shock, ultramental status, and coma. So usually these patients that I have them in shock, where they're on multiple vasopressors in the ICU, like they're on norepinephrine and they're on epinephrine, they're still not responding, then this is where we kind of add steroids with these patients, since a lot of these patients are adrenally insufficient. So how we diagnose this, we'll get labs. They're going to be hypoglycemic, hyperkalemic, hyponatremic, and metabolic acidosis. With these patients, we're going to give them high-dose hydrocortisone, like 100 milligrams IV Q8 hours, and IV fluids, so things like normal saline plus 50% dextrose. Why do we give them the dextrose? Well, it's because they're hypoglycemic, right? It's going to help with their hypoglycemia. And then these patients are monitored in the ICU, like I discussed. So next one's going to be your Cushing's syndrome. This usually involves the zona fasciculata. This causes increased cortisol levels in the blood, and it's usually due to hypercortisolism. And this is either due to an exogenous cause or an endogenous cause, right? So I'll discuss the difference between each one. So etiology, for primary hypercortisolism, primary hypercortisolism, I apologize. As you can tell, Spanish is my first language. So primary hypercortisolism, the most common cause is going to be exogenous causes. So it's going to be a patient that is on corticosteroids, right? So they're taking corticosteroids, they have too much cortisol, and very commonly found more in females and males. Secondary causes we think about are endogenous causes. So exogenous is outside the body, you're doing it to yourself. Endogenous is something in the body. So the most common cause is going to be exogenous, so steroid use. We think about endogenous causes, things like adenomas of the pituitary gland, like we had discussed earlier, right? Cushing's disease, small cell lung cancer, this is a very common one. We think about our ectopic ACTH production. So how is this patient going to present? They're going to have hypertension, moon facies, abdominal striae, truncal obesity, weight gain, the buffalo hump, hyperglycemia/insulin resistance, osteoporosis, amenorrhea. Why do they get amenorrhea? It's because they have GnRH inhibition, depression, easy bruising, poor wound healing, acne, hirsutism, and weakness. So the initial diagnosis for these patients are going to be overnight low-dose dexamethasone tests. So usually dexamethasone in a normal person like you and me, where we don't have increased cortisol levels, it's going to decrease the cortisol level. Why? Because it suppresses the ACTH, right? It suppresses the ACTH. But with these patients, it's not going to do that, right? It's not going to suppress the ACTH. So usually the cortisol level is still going to continue to be high. We're going to do a 24-hour urine cortisol. Usually it's going to be greater than 4 times the normal value. You can do a night salivary cortisol with these patients, and then you're going to do a corticotropin-releasing hormone stimulation test. And this is where you're going to see ACTH that's elevated in cortisol, especially in Cushing's disease. And then you want to make sure that we check an ACTH level just to look for the source, right? We want to make sure you want to rule out an endogenous source versus an exogenous. Remember I said exogenous or steroids, endogenous we think about our small cell lung carcinoma or adenoma of the pituitary gland like Cushing's disease. So in exogenous steroids, like we said, the ACTH is going to be decreased versus endogenous ACTH is going to be increased, which makes sense, right? You have some type of mass there in your pituitary gland. You also want to make sure you get an MRI of the head, just to rule out there's not any type of adenoma. And you can get a chest x-ray if you're trying to rule out squamous small cell lung carcinoma. Small cell lung carcinoma, I apologize, small cell lung carcinoma. Treatment is just going to be removal of the cause, right? If it's exogenous, if it's steroids, you want to taper these steroids gradually, because if you abruptly discontinue them, then this patient is at risk for adrenal crisis, like we discussed, right? So exogenous, we want to think about tapering those steroids. If they have a history of hypertension, so usually these patients do, you can start them with something like spironolactone. This helps with the potassium. Endogenous causes, like we discussed, you can do a surgical transsphenoidal adenectomy of the pituitary gland. And then if it's unresectable, you can do things like ketoconazole, metyrapone, and mifepristone. All right, next one's going to be your congenital adrenal hyperplasia. This refers to several disorders that are characterized by genetic defects in the proteins and enzymes and are involved in cortisol synthesis. So usually the pathophysiology for this is that there's a decreased cortisol production due to a defective proteins and enzymes. What happens is that this releases feedback inhibition of cortisol on the pituitary gland, which causes increased ACTH and can cause hyperplasia. The most common form is going to be your 21-hydroxylase deficiency, and this is usually present during neonatal and infancy. Symptoms for this is going to be diffuse skin hyperpigmentation. Why? Like we discussed, this is due to increased ATH that causes what? ACTH that causes increased melanin. They'll have genital ambiguity, so they'll have clitoral enlargement, labial fusion. This is one of the keys for this one. Salt wasting, there will be hypotensive. Late onset, though, they'll present with premature puberty, hirsutism, which just means a lot of hair in areas where women don't have them, so they'll have beards, chest hair. In addition to that, menstrual irregularities, infertility, acne. Diagnosis for this, you want to get a 17 OHP level, which is going to be increased with these patients. You want to get an ACTH test also. The renin activity is going to be increased, and you can do genetic testing. Treatment for this is just correction of the salt wasting. So you can do glucocorticoid replacement, mineralocorticoid replacement, and then also you want to consider reconstructive surgery in these patients. So once again, congenital adrenal hyperplasia, usually this refers to several disorders that are characterized by genetic defects in proteins and enzymes that are involved in cortisol synthesis. We think about the most common one is going to be your 20-hydroxylase deficiency. This is usually present during neonatal and infancy. They're going to be presenting with skin hyperpigmentation, clitoral enlargement, labial fusion, right, premature puberty, hirsutism, menstrual irregularities, acne, infertility. You want to get 17 OHP levels that are going to be increased. You're going to get an ACTH study. The renin activity is going to be increased, and then genetic testing. Treatment is going to be mineralocorticoid replacement and glucocorticoid replacement, and also reconstructive surgery for these patients. So just going over kind of the adrenal gland, because this is something that's very commonly tested also. So with the adrenal gland, you have the capsule you have the zona glomerulosa, the zona fasciculata, the zona reticularis, and the medulla, right? The capsule we think about is just the top capsule. The zona glomerulosa is under the capsule, so this is usually responsible for mineralocorticoids. So the zona glomerulosa is usually associated with what? Mineralocorticoids, right? And then with these patients, the next thing we think about zona fasciculata. This is responsible for glucocorticoids. The zona reticularis is responsible for androgens, and the medulla is responsible for catecholamines. All right, next topic is going to be diabetes. This one is very, very commonly tested. And given now that we have so many patients that are diabetics, we have so many children that are being diagnosed early with type 2 diabetes, is something that you need to know. And I think whatever practice you go into, it's really important to know. So diabetes in general, what is it? So it's basically, in layman's words, it's going to be trouble moving glucose, and this is kind of how I explain it to my patients, from moving sugar from the blood into the cells where it's needed for energy, right? So what does insulin do? Insulin decreases blood glucose levels, and it's produced by beta cells. Glucagon, it increases blood glucose levels, and it's produced by alpha cells, and it's increased glucogenesis by the liver. And then in regards to polyuria, kind of what happens there is that since glucose is osmotically active, water follows it, and then this causes an increase in urination. So that's why we see polyuria in patients that are in severe DKA. Polydipsia is due to increased urination, so the patient becomes dehydrated, and it triggers this thirst mechanism where they start drinking water, and they're drinking a lot of water. Polyphagia, that's when you're eating a lot, and what happens is that you have no glucose in your cells, so the cells start starving for energy, because we said that glucose is needed for the cell to get energy. So you have no glucose, cells starve for energy, so you get lipolysis and muscle breakdown, which can cause weight loss and catabolic state, which can cause hunger. So patients could be eating a lot. And then you're going to have glycosuria, which is an increased glucose levels in the blood. This is filtered in the kidneys. Some of it spills out into the urine, so you get sugar in the urine. And this is in your UA, this is what you're going to see is glucose in your urine. You can also see ketones. Okay, so you have two types of diabetes. You have type 1 and type 2. Type 1 is autoimmune, and this is about 10% of diabetes. And usually what happens is that the T cells attack the pancreas, and the T cells react to antigens from their own body cells. So you get loss of self-tolerance. Versus type 2 diabetes, which is the most common one we're going to see, it's about 90%. This is where the body is able to make insulin, but the tissues don't respond to it. So you have impaired B cell function, and you have increased insulin resistance. So type 1 diabetes, like we discussed, it's an autoimmune pancreatic islet beta cell destruction. So you have decreased insulin production, and the fact that you have decreased insulin, you're going to have increased glucose. Right? So your plasma glucagon is increased. This is very commonly found in younger children, although now you can kind of not really say the same, because type 2 diabetes now, due to the society we live in, fast food, etc., we're seeing more type 2 in children. But for testing purposes, type 1 is most commonly arises in children and young adults. So usually these children will get diagnosed with type 1 diabetes. And like I said, this is autoimmune, usually genetics. Some of the genes we think about is HLA-DQ, HLA-DR3/HLA-DR4 on chromosome 6. These patients, since they have an autoimmune disorder, they're at increased risk for other autoimmune disorders, or already have other autoimmune disorders. So we think about increased risk for autoimmune thyroid disease, right? Adrenal insufficiency, pernicious anemia, celiac disease, and then vitiligo. How is this patient going to present? They're going to have polyphagia, glycosuria, polyuria, polydipsia. Why do they have polydipsia? Like we discussed, this is due to increased urine and dehydration. So they're peeing so much, they're having to drink a lot of water. Weight loss, ketonatremia/ketouria. So like I said, you'll get a urine analysis on these patients, and they have ketones in their urine, ketones in their blood. It's associated with vitiligo, pernicious anemia, and celiac disease. And the reason why I'm saying this is because I've seen it tested, and I'm repeating this. So diagnosis for these patients, you want to get a glucose level, right? But it's going to be a fasting glucose level, and they have to have a glucose level greater than 126 on 2 occasions. You also want to get a hemoglobin A1C, and it's going to be greater than 6.5 with these patients. How I describe the hemoglobin A1C to my patients is that you have a bowl of cereal, right? And you have cornflakes, okay? Well, what if you get those cornflakes and you take half of those cornflakes and you replace it with your frosted cornflakes? So the cornflakes are going to be the red blood cells. The frosted cornflakes are going to be those red blood cells that are covered with sugar. So if you have a bowl of cereal and the majority of those cornflakes are not cornflakes, but instead they are frosted cornflakes, then that's how I describe it, of how many cells are covered with sugar, or how many of these cornflakes are covered with sugar with your hemoglobin A1C. Hopefully this is helpful for you. Definitely it is for me, and that's how it was described by one of my attendings, and how I describe it whenever I'm talking to my patients in regards to their hemoglobin A1C. You also get a random glucose level. It's going to be greater than 200, and you can get an oral glucose tolerance test also, okay? So you're going to load them with 75 grams, and after 2 hours, they're going to be greater than 200. And also big thing is that they're going to have an absent C-peptide. That's big because in patients with type 2 diabetes, since it's not autoimmune, everything's working, they just have insulin resistance, their C-peptide is going to be increased. Versus type 1, they just have an absent C-peptide. So treatment with these patients, they're on lifelong insulin therapy. So usually they're on a combination of rapid and long-acting insulin. And it's really important that these patients check their blood sugars, right? They're going to be in a strict glycemic control. And usually with these patients, we think about our insulins. This is very highly tested, so make sure you know the difference between these. Our rapid-acting insulin, we think about Lispro and Aspart. Our short-acting insulin, we think about regular insulin. Our intermediate-acting insulin, we think about our NPH insulin. Our long-acting or basal insulin, which is one that I commonly use in the ICU, is going to be Glargine and Orlantus, and then also Levemir. Something that's very commonly tested is also Dom phenomenon and Shimogi effect or Shimogi effect. So Dom phenomenon and Shimogi effect are all very pertinent only to type 1 diabetes, and that's something you have to know. You're not going to find this in type 2 diabetes, and I like to trick you with that, right? So type 1 only associated with Dom phenomenon and Shimogi effect. So Dom phenomenon, it's going to be hyperglycemia between 3 a.m. and 8 a.m. So if it's a patient that wakes up, they're hyperglycemic between 3 a.m. and 8 a.m., Dom phenomenon. Shimogi effect is usually due to nocturnal hypoglycemia, and this usually is around at 3 a.m., and it leads to a surge of counter-regulatory hormones that causes high glucose levels by 7 a.m. Okay, type 2 diabetes. We said it's about 80% of diabetes in general. And with these patients, they make insulin. So our body makes insulin. But the thing that is occurring is that the tissues don't respond to it. So they have impaired B cell function and increased insulin resistance. The etiology by far is going to be obesity, right? Middle-aged adults, lack of exercise, hypertension, genetics also. If they have a very strong family history of a type 2 diabetes, the patient is very prone to getting type 2 diabetes also. Beta cell hypoplasia and hypertrophy, and then other things we think about in women is polycystic ovarian syndrome. So these patients are going to be presenting with hyperglycemia, polyphagia, where they're eating a lot, glycosuria, right? They're urinating and they have glucose in their urine. Polyuria, urinating a lot. Polydipsia, drinking too much water. This is usually due to urine and due to increased urine and dehydration, like we discussed. Acanthosis nigricans is one that's very commonly found. Skin physical exam, that's usually what you find in the back of the neck of patients. It's like this velvety hyperpigmentation that you'll see. In women, they're very prone for getting candidal infections. So if it's a woman that's already had like 3 infections in 1 year of candidiasis, maybe you want to get a glucose level on them or a hemoglobin A1C to rule out diabetes. It's also associated with hypertension, hyperlipidemia, and atherosclerosis. So with these patients, we're going to diagnose them. We're going to get an A1C, right? It's going to be greater than 6.5. A fasting glucose greater than what? 126 on 2 occasions. Random glucose greater than 200. You want to do an oral glucose tolerance test, load them with 75 grams, and then after 2 hours, it's going to be greater than 200. That's positive for diabetes. And then we said we get a C-peptide. It's going to be increased in type 2, but absent in type 1. And then it's really important, the PANCE has kind of moved on to the screening. They like to do a lot of screening questions, so this is why I also included in this. So who do you screen for type 2 diabetes? You're going to screen any adult with a BMI greater than 25, triglyceride level greater than 250, or if their HDL is less than 35. Okay? But you usually starting at age 45, you screen them regardless. And then you screen them every 3 years if normal after that. So treatment, the first line treatment is diet and lifestyle changes, okay? That's going to be the first line treatment. Like I said, the PANCE is moving towards more lifestyle management, things for like heart disease, of course, unless it's very severe. But first line is going to be lifestyle changes. Second line is going to be oral medications. The first line is going to be metformin, but the thing about metformin is that it's known for causing lactic acidosis, and it's also contraindicated in patients that have a GFR less than 45. Third line is going to be insulin. So insulin is going to be the third line. That's if a patient that is not responding, has tried, for example, lifestyle changes, it hasn't worked. And then second line is, for example, a patient that comes in and you put them on metformin. Third line is going to be insulin, okay? With insulin, it's important that you should check their blood sugar daily. Anything less than 70 is going to be hypoglycemia. In the ICU, hypoglycemia is a lot more dangerous than hyperglycemia, so it's really important that these patients check their sugar levels. I actually had a patient that was a type 2 diabetic, and she was just, her regimen for her glucose was just all over the place, where she was coming into the emergency department being hyperglycemic, and then the next day she had syncopal episodes where she was found to have a glucose level of 40. And this happened multiple, and I felt bad because she was going, like, she was just being managed poorly by her doctors. Unfortunately, how she came to me is that she had such a severe fall, syncopal episode. Her glucose was like 20 something, where she syncopized and they found her on the ground, and she ended up having a cervical fracture. So she ended up being paralyzed, and it was very, very sad. Just to give you an example. So once again, all of these diabetics need to be on ACEs or ARBs. Why? Because it protects their kidney functions regardless of what their blood pressure is, because a lot of these patients are prone to getting kidney disorders. So once again, type 1, type 2, type 1 is autoimmune, right? They're going to have an absent C-peptide. Usually these patients need lifelong insulin therapy. Usually it's a combination of a rapid and long-acting, so it'll be a basal regular insulin and then a Lantus at night. And like we said, it's autoimmune. There's beta cell destruction, and usually it's diagnosed in your younger children. And they're going to be presenting with polydipsia, polyuria, they'll have ketones in their urine, ketones in their blood. Type 2 diabetes is the most common one. It's about 90% of diabetes nowadays. And this is due to the body makes insulin. It's just that the tissues are not responding to the insulin well. So they have impaired B cell function, and they have increased insulin resistance. So these patients are going to be presenting with polyphagia, polyuria, polydipsia, acanthosis nigricans. We think about polycystic ovarian syndrome in these patients. They're going to have recurrent candidal infections, especially in your woman. Diagnosis for both is going to be hemoglobin A1C greater than 6.5. You want to get glucose levels for them, and fasting glucose is going to be greater than 126 on 2 occasions. Usually if it's less than that, 126, we think about our pre-diabetic patients, right? So usually with these pre-diabetic patients, you want to make sure that you counsel them and tell them that they're at risk of diabetes. Lifestyle changes is going to be the first line for these pre-diabetic patients, because you want to prevent them from going over 126 and becoming full-blown diabetics. And then you want to get an oral glucose tolerance test for both type 1 and type 2. It's going to be random, and usually you'll give them a gram of 75, and then after 2 hours it's going to be greater than 200, and then a random glucose level is also going to be greater than 200. You want to screen any adult for type 2 diabetes with a BMI greater than 25 and triglyceride levels greater than 250 if they're obese, if they have an HDL level less than 35, regardless, so you always start at age 45, according to the U.S. Preventative Task Forces. Treatment for type 1 is always lifelong insulin therapy. Treatment for type 2, first line is going to be diet and lifestyle. Second line is going to be metformin. You want to watch for patients that have GFR less than 45. And then third line is going to be insulin, right? And then all these patients that are type 2 diabetics are placed on ACEs and ARB because they're very prone for getting kidney disorders. All right, next one's going to be your hyperosmolar hyperglycemic state, also known as your HHS. The key about this one is that it's very commonly found in your type 2 diabetics, okay? And that's how you differentiate between DKA and HHS. DKA is type 1, HHS is type 2. DKA is type 1, HHS is type 2. The other way you differentiate this is between the glucose levels, okay? So if a patient presents with a glucose level for example, your HHS, it's going to be very high. Now, is this a case in real life? No. But exam-wise, if it's between 600 to like 2400, you think about HHS, right? Versus your DKA, the glucose is going to be about 250 to 600. So in HHS, the glucose is going to be a lot higher, like super high in the 2000 levels. Versus DKA, the glucose is going to be not that high. It'll be 250 to 600. So it's kind of how you can differentiate between both of them. If somewhere in the story, it doesn't tell you whether it's a type 1 or type 2. So HHS, usually with these patients, they're going to be dehydrated. They're going to be in a very hyperglycemic state. They'll have little to no ketosis, and that's how you can also differentiate between DKA and HHS, is that in DKA, they have ketosis. The pathophysiology for HHS is that they have increased plasma osmolarity due to extreme dehydration and concentration of the blood. So they're going to have increased glucose in their blood. They're going to have this hyperosmolar state where water leaves the body cells and enters the blood, and they're just going to have total body dehydration. Like we said, this is most commonly found in your type 2 diabetics. Usually very commonly found in your patients that are non-compliant with their medications or any type of acute illness. For example, did they have a stroke, an infection, pancreatitis, myocardial infarction? Usually they're going to be presenting with polydipsia. It's going to be a gradual onset, polyuria, altered mental status, neurological abnormalities, weight loss, weakness, fatigue, dehydration, and blurred vision. Diagnosis, blood glucose, like we said, is going to be very elevated, 600 to 2400. Usually in the question stems, it'll be like 800, like 1000. And they're going to have increased serum osmolality greater than 3200. Glucosuria, so that means glucose in their urine. It's going to be very elevated if you get a urine analysis. Increased BUN. Most of these patients have acute kidney injuries, so not only is their BUN going to be increased, but the creatinine is going to be increased. And this is just because they're very dehydrated, right? So usually we think about pre-renal causes of these AKIs, hypovolemia. They will have no ketones, no acidosis, and they're going to have hyponatremia. So like we said, little to like no ketones for HHS versus DKA, you're going to see your ketones. Treatment's going to be IV fluids because these patients are very dehydrated and you're just giving them IV fluids. You want to keep them euvolemic to hypervolemic. You want to replete their electrolytes, especially their potassium. Give them IV insulin after fluid resuscitation. And then supportive measures, like we said, are ABCs, airway, breathing, circulation. Most of these patients get admitted to me, to the ICU. So once again, with HHS, type 2 diabetes, right? No ketones, okay? Glucose is going to be up the roof, 600 to 2400. Treatment, IV fluids. Most of these patients need aggressive resuscitation. Most of these patients are going to be in acute kidney injuries. Creatinine, BUN is going to be up the roof. Replete your electrolytes and then give them IV insulin after you've resuscitated them. All right, diabetic ketoacidosis. This is where the cells need energy, so they're not getting any energy, right? So they start using ketone bodies to get energies, and this causes increased acidity of the blood. And this is an emergency. I actually admitted one of these patients about a week ago who went into DKA and had a post-cardiac arrest and received CPR for about 20 minutes. Can you imagine? And surprisingly, last time I saw him was on Wednesday. I haven't been to the ICU. I'll be back tomorrow, so I'll see if he's still there. It's Saturday today, and I go in tomorrow, Sunday. And I admitted him. So when he came in, he was post-cardiac arrest. He had about 10 minutes of chest compression, CPR, where they finally achieved Rosh, the return of spontaneous circulation, where he had a palpable pulse, etc. So when he got to me, and I'm not lying, his glucose was like 2,500, and he was a type 1 diabetic. And this is what I'm saying, where you want to kind of split textbook from like what you're going to see in real life medicine. So 2,400, right? If I tell you that the glucose is 2,400 and you just know the patient's a diabetic, you're like, this is going to be type 2 diabetes, it's going to be HHS, right? Because these glucose levels are just crazily abnormal. Well, that wasn't the fact. He was actually a type 1 diabetic. So like I said, just for textbook, just know that 250 to 600 is going to be your type, your DKA, versus like 600 to 2,400 is going to be your HHS. But this patient, he was in DKA, UA, he had positive ketones that were super high for him. And then we were trending ABGs because his pH was 6.8 and his bicarb was 2. So he was like in florid, anion gap, metabolic acidosis. This is where you think about your mud piles, right? Like you think about methanol, uremia, diabetes, and then he was in florid DKA. His lactate level was like extremely high. And so I just remember when he came here, he was like intubated. I was lining him. I was placing like a central line. And then, yeah, he was just a disaster. So when he came in, he was a type 1 diabetic. He had bilateral enucleation. So he had both of his eyes removed because he had severe type 1 diabetes that had just like destroyed all his eyes. He has end-stage renal disease. He's on hemodialysis. So I had to connect him to CRT, which is continuous renal replacement therapy, which kind of is like hemodialysis, but it's more emergent in these patients where it kind of just cleans their kidneys. And I wanted to just, like, his kidneys weren't working. I needed to clear that metabolic acidosis. So we connected him to CRT, started him IV fluids, and was just like bolusing him with IV fluids. And on top of that, maintenance IV fluids, like trending the ABGs, looking at the, and then he was hyperkalemic when he got here. So yeah, anyways, that's just an example of how these patients came. Like I said, he went into post-cardiac arrest, so he ended up dying for about 10 minutes, and then we ended up getting him back. But that's just an example of diabetic ketoacidosis, and just to tell you that with these patients, they don't always come how they tell you in regard to the book. So diabetic ketoacidosis, like we said, this is an emergent complication. Usually what happens is that stress triggers release of epinephrine, releases glucagon, which causes increased blood sugar, which causes loss of glucose in the urine, loss of water, dehydration, and so then you start getting this ketoacidosis. So etiology, so something must cause a patient to push him into going into DKA. So this patient, we ended up getting a chest x-ray, he had pneumonia. So usually something's going to trigger it, like an infection, like we said, myocardial infarction, CVA, illegal medications, idiopathic, or sometimes if they're not complying with their medications. I wouldn't be surprised if he was not complying with his medications. And then it's also very commonly found in your new diabetics because they don't know how to control their sugars. I also had one patient that presented in the DKA when I was in the transplant ICU. So in the transplant ICU, they do a lot of transplants, and now what they're doing is that they're transplanting pancreas, which is really, really interesting. So if you, in our type 1 diabetics, we do transplants, a pancreas transplant, and we had one patient that came in. He was a type 1 diabetic since he was like 13, I think, and he was like 30 something, and he was very, very excited because he was going to get his own pancreas. Unfortunately, he stopped checking his glucose level, and he ended up having the whole pancreas thrombosed, unfortunately, and so he had to go back to surgery, came back super like hyperglycemic, florid DKA because he wasn't checking his sugar levels and was not compliant. He was just excited that he got a pancreas, and he's probably like, I got a new pancreas, it's working, I don't have to check my glucose levels anymore. So he came in florid DKA, thrombosed, like pancreas. He ended up having to go to the operating room and having the pancreas removed. So that was really, really sad. But there's hope for these patients. So patients going to be presenting with DKA, polyuria, polydipsia, polyphagia with fatigue, nausea, vomiting, abdominal pain, dehydration, altered mental status, loss of consciousness, dry skin, fruity breath. I've yet to smell that. fruity breath. Why? This is due to ketone body acetone. Kussmaul respiration, I've definitely seen that. That's where they have the rapid and deep breathing. This causes decreased CO2 and decreased acidity, so they're trying to compensate for their metabolic acidosis by using respiration. So diagnosis for these patients, you're going to see ketonuria. So you're going to see ketones in the urine. You're going to see glucose in the urine. You're going to get a random blood glucose level, which is going to be elevated 250 to 600, although it's not always the case like we discussed. They're going to be florid metabolic acidosis with an ABG, like I said. It's pH of 6.8, bicarb of 2, decreased bicarb, usually less than 18, but I gave an example, bicarb of 2. You want to get a sodium level, serum level for ketones, get their potassium level for these patients. Usually they're hypokalemic, but it just depends. Like I said, it's not always textbook-wise, but textbook-wise, it's going to be hypokalemia. Treatment, IV fluids for dehydration, IV insulin, and then potassium replacement, definitely before the insulin, and supportive measures, just admit them to the ICU. So once again, DKA, common in type 1 diabetics, like we discussed, right? It's with these patients, you're going to be hyperglycemic level between 250 to 600. You want to make sure you go through your ABCs. Start them on IV fluids. It's going to be your first line thing. Replete them with IV fluids, IV insulin also, and then potassium replacement. But you're going to do that before you give them insulin. Okay, so potassium replacement before you give them insulin. All right. So what are some of the complications of diabetes? So this is very commonly tested, so that's why I wanted to include it. So this includes both microvascular and macrovascular. And with these patients, short term, they can get acute hyperglycemia, like we discussed, DKA or HHS. And just as this is due to poor glycemic control. And then they can also get acute hypoglycemia, like I discussed, the patient I had earlier. And this is very life-threatening, and this is usually secondary to therapy, especially if they're not well controlled on their insulin regimens. It can get super hypoglycemic. Macrovascular causes, we think about atherosclerosis. This is due to chronic inflammation and arterial injuries. So a lot of these patients are at increased risk for getting coronary disease and also myocardial infarctions. And the thing about these patients with myocardial infarctions is that they have, with these diabetics, silent MIs. So usually these patients will die of myocardial infarctions without being symptomatic, right? So we think about our symptoms, think about your jaw pain, your shoulder pain, your chest pain. Sometimes these patients don't present with that, right? Why? Because they're having all this damage to their macrovascular damage that they just don't feel these myocardial infarctions. There are also risks for PAD, so peripheral arterial disease, which is what my patient had when I was telling you about that I'm currently taking care of. So they'll have this cold, hairless, lower extremities with diminished pulses. I kid you not, the nurses would go up to me and they would be freaking out because they couldn't find a pulse on the patient with Dopplers. And what I did, I just grabbed my ultrasound and I showed them with the ultrasound, and we looked at the arteries. I'm like, look, these arteries, and you can see they're non-compressible, and you can see just how how much atherosclerosis they had, because they usually on the ultrasound, when you see it, it's just like a white rim that you'll see around the vessels. And then microvascular, usually these patients, due to chronic hyperglycemia, they have impaired cell membrane function, osmotic damage, and tissue injuries. So we think about retinopathy, like I discussed my patient that I had, that he became blind, so he had bilateral enucleation. So usually on your exam, on your ophthalmic exam, do we do that in the ICU? Definitely not. You'll see cotton wool spots or flame hemorrhages that can cause blindness. Usually these patients need to be referred to ophthalmology. So any patient that you diagnose with diabetes you need to make sure that you also refer them to an optometrist. Okay, they need to get an annual exam. Also nephropathy, usually this is due to efferent, and glomerulus damage. And what happens is that these patients get microalbuminuria, and like I discussed, most of these patients can also go to end-stage renal disease, and that's why you place them on ACEs and ARBs. And when they've already gone to kidney failure, like the patient I had, they need hemodialysis. Neuropathy, which is what my patient also had, they have severe polyneuropathy, so they have decreased sensation in their toes and fingers. They'll get that stocking and glove distribution. You can usually do a monofilament test with these patients, and treatment's usually gabapentin, which is what we use a lot in the ICU. You can also do Lyrica and Cymbalta, but usually gabapentin is going to be the one that works. Diabetic ulcers, I can tell you not how much this patient had everything. He's like textbook what I'm telling you, except for the hyperglycemia and like the potassium levels. But with these patients, it's usually due to nerve damage and poor blood supply. So usually these patients need debridement and antibiotics and can need amputation. So my patient, he had a really bad sacral ulcer, and then he also had multiple just diabetic ulcers, and we just consulted wound care, and they come and they address the wounds. And then they can also get autonomic dysfunction. Gastroparesis is a big one that I see in these patients. They usually complain of abdominal pain, or they haven't had a bowel movement in a while. So usually lifestyle modifications, you can do metoclopramide, erythromycin for these patients. They can also get neurogenic bladders and impotence. You can also get immune dysfunction. So hyperglycemic environment enhances virulence, right? So we think about or fungus or just bacteria that like this glucose. It's like the perfect environment for them. So what happens is that this decreases leukocyte adherence, impairs neutrophil phagocytes. So these patients are prone for getting candidal infections, urinary tract infections, Pseudomonas, malignant otitis externa, right? We'll probably discuss that once I go into the E and T topic. And these patients are immunocompromised in essence. All right, make sure you know diabetes, very commonly tested. Type 1 and type 2, the differences, right? HHS versus DKA, and what are the long-term complications of untreated diabetes. So neoplasms, let's go into all the neoplasms. So let's go into multiple endocrine neoplasia, also known as MEN syndrome. So these are 3 autosomal dominant syndromes that are associated with hormone-producing neoplasms, right? So we have 3. Let's talk about MEN1. Okay, so MEN1 is going to be your 3 Ps. You're going to have primary hyperparathyroidism. That's going to be the main disease. You're also going to have pancreatic tumor. So we think about our Zollinger-Ellison syndrome, gastrinomas and insulinoma, and pituitary adenoma. So once again, MEN1, 3 Ps, primary hyperparathyroidism. That's going to be the main disease. A pancreatic tumor, either your Zollinger-Ellison syndrome, your insulinoma for these patients, and or gastrinoma, plus a pituitary adenoma. Treatment for these patients is going to be a parathyroidectomy, excision of the pancreatic tumor, a transphenodal surgery for excision of the pituitary adenoma also. MEN2A, we think about 1M and 2Ps. So we think about our medullary thyroid cancer. That's going to be your main disease, your pheochromocytoma, and your primary hyperparathyroidism. Treatment is going to be your thyroidectomy, adrenalectomy, and parathyroidectomy. MEN2B is going to be your 3Ms and 1P, so it's going to be your medullary thyroid cancer, which is going to be the main disease, pheochromocytoma, plus a morphoid body habemus, plus mucosal neuromas. Treatment is going to be thyroidectomy and adrenalectomy. So once again, how I think about it is MEN1, you have 3 Ps, so primary hyperthyroidism, a pancreatic tumor, and a pituitary adenoma. MEN2A, you have 2 Ps, and then 1M. So the 1M is going to be your medullary thyroid cancer. The 2 Ps are going to be your pheochromocytoma and your primary hyperparathyroidism. And then your MEN2B is going to be your 1P, so 3P, 2P, 1P. This is going to be your 1P and 3M. So your Ms are going to be your medullary thyroid cancer, your morphoid habitus, body habitus, your mucosal neuromas, and then your 1P is going to be your pheochromocytoma. This is very commonly tested, so make sure you know this. All right, pheochromocytoma, this is another thing that's very commonly tested. This is going to be a catecholamine secreting tumor that arises from the adrenal medulla. It causes excess norepinephrine and epinephrine that causes sympathetic overdrive. So we think about our rules of tens, right? Bilateral, familial, pediatric, malignant, extra-adrenal, and MEN2A/MEN2B. Usually this patient is going to be presenting with a triad of episodic headaches, hypertension, diaphoresis, tremors, anxiety, flushing. They'll have 5 Ps like pressure, pain, perspiration, palpitation, and pallor. Diagnosis is the initial one, and this is where they love to test you on, is that you're going to see increased urinary / plasma fractionated metanephrines and catecholamines. But the most accurate test is going to be your CT and MRI of the adrenals, right? Because this is where you're going to see that catecholamine secreting tumor. Treatment's going to be your surgical resection of the tumor, but it's really important that preoperatively, before they go and they get that tumor resected, that you give them some type of alpha blockade. So things like phenoxybenzamine is going to help you control the blood pressure, and then propranolol. So first, you're going to give them an alpha blockade and then propranolol. So once again, pheochromocytoma. It's your triad of episodic headache, hypertension, and diaphoresis. We think about our 5 Ps, which is going to be pressure, hypertension, right? Pain, that headache. Perspiration, palpitation, pallor. Diagnosis is going to be your initial one's going to be your urinary and plasma fractionated metanephrines and catecholamines are going to be increased, and the most accurate is going to be a CT and MRI of the adrenals. Treatment's going to be surgical resection of the tumor, but preoperatively, you have to make sure that you first give them an alpha blockade, so things like phenoxybenzamine. This is going to help control the blood pressure, and then you're going to give them propranolol. Okay, next one's going to be your primary hyperaldosteronism, also known as your CON syndrome. This is going to be excessive aldosterone from an autoimmune secretion from the adrenal gland. Pathophysiology is that you have this aldosterone secretion independent from the renin-angiotensin system, also known as your Rosh. Etiology, most common cause is going to be an adrenal adenoma. This is also known as your CONS, right? They can also have bilateral adrenal hyperplasia, adrenal carcinoma, and usually commonly found between the ages of 30 to 50, most commonly found in African Americans. How is this patient going to present? They're going to have refractory hypertension, headache, muscle weakness due to hypokalemia, palpitations, arrhythmias, polyuria, polydipsia, nausea and vomiting, abdominal distension, and diagnosis is usually going to be screening. You do a plasma aldosterone to plasma renin, right? If it's positive, you're going to have an increased ratio. The definitive diagnostic test is going to be a saline infusion test, and this causes persistently increased aldosterone. Lab chemistries, you're going to see metabolic alkalosis, hypernatremia, hypokalemia, and then you're going to do a CT and MRI of the adrenal glands. Treatment is treat the underlying cause. So if it's an adenoma, then you want to make sure that you do an adrenalectomy. You want to normalize the blood pressure, normalize the chemistry. If the patient is not a surgical candidate, then you're going to do medical therapy. So first-line medical therapy are going to be things like spironolactone. This is going to be an antihypertensive, and then it also inhibits the action of aldosterone. So once again, primary hyperaldosteronism is just too much aldosterone, right? We think about adrenal adenoma, like CON syndrome, which is going to be the most common one. This patient is going to be presenting with hypertension that is refractory. So any patient that comes in, right, they're hypertensive, they're young, like they're in their 30s, they're in their 20s, or even if they're older and you've tried them on multiple antihypertensives and they're at max doses and they're still not responding and their blood pressure is not budging, maybe you want to start ruling out things like hyperaldosteronism, okay? So always look for that in the question stem. If it says that despite this patient being on X, Y, and Z medications and they're at high dose, like, and they're unable to control their blood pressure, like, think about primary hyperaldosteronism. So with these patients, send a plasma aldosterone to plasma renin ratio, right? Also, the key for this one, like we said, metabolic alkalosis, hypernatremia, and hypokalemia is going to be a key for their labs. And then refractory hypertension. Treatment is going to be adenoma, primary, definitive. If the patient is not a surgical candidate, then you can do something like spironolactone. Next one's going to be your SIADH, or syndrome of inappropriate antidiuretic hormone, or how my doctor calls it, excessive ADH, because there's no such thing as inappropriate ADH because the brain creates it. Anyways, I think that's very interesting. If it works for you, it definitely works for me. So excessive ADH versus diabetes insipidus is decreased ADH, excessive ADH is SIADH. So with these patients, they have an increase in ADH production. They have increased sensitivity to ADH. So what happens in regards to the pathophysiology is that they have increased ADH secretion. So water is drawn out of the urine into the kidney tissue. It concentrates the urine, which causes increased urine osmolality, causes water retention. So this decreases serum osmolality, which makes sense, right? Because the body is holding onto the water, which is going to decrease the osmolality, or the amount of electrolytes that are present in the body. It's going to cause an osmotic fluid shift, which can cause cerebral edema and increase intracranial pressure. So this patient is going to present with hyponatremia, so low sodium levels in the blood, because the body is holding on to all the water, versus diabetes insipidus, the patient is going to be hypernatremic because the body's getting rid of all the water. That's how you differentiate between both of them. So etiology, very commonly found, like we said, it's increased pituitary ADH secretion. So this is why I see this a lot in the ICU, and why I get asked about it all the time by my attendings, because I want to make sure I know the difference between DI and SIDH and cerebral salt wasting, which we're not going to discuss. But I get pimped on this so much in the ICU because I see this a lot in any type of cerebral disorder or brain disorder. Like I said, your hemorrhagic shock, your hemorrhagic strokes, your subarachnoid hemorrhages, etc. So any type of neurological disease like stroke, bleeding, infection, trauma, also pulmonary disease like COPD, certain medications like SSRIs can also cause SIADH. So when we think about also other causes, we think about ectopic ACTH secretion, so that's outside the brain. We think about your lung cancers, especially your small cell lung cancer. Also, we think about paraneoplastic syndrome. How is this patient going to present? They're usually asymptomatic. If they do have symptoms, it's going to be symptoms due to hyponatremia. Usually, if it's mild symptoms, you're going to have anorexia, nausea and vomiting, headache, muscle cramps. If it's moderate, they'll have muscle weakness, lethargy, confusion, and disorientation. Severe symptoms, it's going to be your seizures, altered consciousness, altered mental status, and this is usually due to cerebral edema. Diagnosis, like we said, you're going to see hyponatremia, so it's going to be a sodium level less than 135. Increased urine osmolality, which makes sense. Decreased serum osmolality. And the reason why you're going to see increased urine osmolality is because the body's holding on to all the water, so your urine is going to be very concentrated, versus in your body, your serum osmolality is going to be very decreased because you have so much water that is diluting everything else, all the other electrolytes, all the sodium. These patients are going to have normal renal function, adrenal function, and thyroid function, and their plasma ADH is going to be elevated because they have excess ADH. Treatment is going to be fluid restriction and increased salt intake. For initial symptoms, you can also do hypertonic saline, which is, most of these patients get admitted to the ICU, like the ones I've been taking care of. Also diuretics like furosemide. I had one patient that was taken care of in the transplant ICU that was admitted to us because there was no other beds in the ICU for hyponatremia, and her sodium was 120. And this is exactly how she presented. She was altered, etc. The thing with hyponatremia is that it's super complicated, right? But with these patients, also make sure that you want to look at the medications, and that's one of the things, is that she was taking certain medications that were causing her to have SIDH. Also, medical management for this, you can also do demeclocycline, like these are ADH antagonists. You can also do IV conivaptan and PO-tolvaptan. These are vasopressor antagonists, but I'll be honest with you, we don't use them because my doctors are very weary because it can cause like really rebound just problems in general. So they don't really use these, but for exam-wise, do demeclocycline and IV conivaptan and PO-tolvaptan. So once again, SIDH, too much ADH in the body, or how my attending says, excess ADH. Very commonly found in any patient that has any type of cerebral or brain problem, like your strokes, your tumors. We think about your bleeding, your subarachnoid hemorrhage, subdural hemorrhages, etc. These patients are going to have hyponatremia. They are going to have, in regards to their urine, osmolality is going to be increased. The serum osmolality is going to be decreased, right, because they're holding onto all the water. And treatment for this is going to be fluid restriction and increased salt intake, hypertonic saline. You can also give them diuretics like furosemide. Okay, next one's going to be your thyroid carcinomas. So thyroid carcinomas, there's several types. This is very commonly tested, so make sure you know these. The most common thyroid cancer, it's going to be your papillary carcinoma. This is what they like to test you on, which one is going to be the most common one, which one has a worse prognosis, etc. So the most common thyroid cancer is going to be your papillary carcinoma. So it's really important that you know this because, like I said, this is very commonly tested. So most common thyroid cancer is going to be your papillary carcinoma. This is about 60 to 70% of all thyroid cancers. Usually they'll have a history of radiation exposure, more commonly found in females and males. The good thing about this one is that they have a really good prognosis. The next one is going to be your follicular carcinoma. This is about 15 to 20% of your thyroid carcinomas. This one spreads hematogenously with distant metastasis to the lung and bone. And then you have your medullary carcinoma. This is about 5% of your thyroid carcinomas. The thing about this one and what they like to test about is that it produces calcitonin. And this is the only one with elevated calcitonin. It's associated with MEN2A, Sippel syndrome, and MEN2B. So once again, medullary carcinoma produces calcitonin associated with MEN2A and MEN2B. And then you have your anaplastic carcinoma. This is the least common one, about 1 to 2%. This one spreads by direct extension, has the worst prognosis, and is the least common. So once again, out of all of them, the one with the worst prognosis is going to be your anaplastic carcinoma for your thyroid carcinomas, and is the least common. The most common one is going to be your papillary carcinoma. It's about 60 to 70% of all thyroid cancers. It's going to be a history of some type of radiation exposure, more commonly found in females, and has a really good prognosis. And the one that is associated with calcitonin, produces calcitonin, and associated with MEN2A and MEN2B is going to be which one? This one's going to be your medullary carcinoma. So overall, thyroid carcinomas are going to be more commonly found in women than in men, usually under 20 and or over the age of 65. Like I just said, they're going to have a history of neck radiation and then also family history. They're going to be presenting with stating that they have a pressure in their neck, dysphagia, choking sensation, which makes sense, right? Because you have an enlargement that is pressing against, that is causing pressure. Hoarseness also, nodule on the anterior neck, hard fixed nodule, that's a big one, right? A hard fixed asymmetrical nodule. These are very rapidly growing. Diagnosis, usually it's a clinical diagnosis. Initial though, you want to do an ultrasound, so you're going to do an ultrasound of the thyroid, and just to make sure that it's not abnormal. If it's abnormal, then you're going to confirm with a fine needle aspiration. Usually labs, you'll see a normal thyroid function, and treatment's going to be endocrine referral with these patients. If it's hyperfunctioning, then you can do radioiodine ablation and or surgical excision. Okay guys, so now we're kind of done with the main disorders that you're going to see on endocrinology on your PANCE exam. The other things I wanted to touch on were just going to be some of your medications, okay? So insulin. So insulin, it's an exogenous peptide hormone. It reduces the amount of glucose in your blood, and it moves glucose into the cells instead of circulating in the blood. Usually it's administered subcutaneously, right? It's broken down in the GI tract. The quickest absorption is going to be in the abdomen, thighs, arms, and buttocks. There's also insulin pumps that patients nowadays have. So regimen, you can take it as a bolus. This is usually taken before meals to counteract post-meal hyperglycemia. It's taken with meals. You also have basal insulin. This is taken to keep a steady background level of insulin. It regulates basal blood glucose, and it's taken either once a day or twice a day. You have basal bolus. This maintains basal blood glucose and bolus before each meal. And then you have your sliding scale. This is the one that I see a lot in the hospital. We do low dose sliding scale insulin, moderate dose sliding scale insulin, and high dose sliding scale insulin. This is when the blood glucose fluctuates rapidly due to metabolic stress or infection or illness, and it's measured every 4 to 6 hours and then dosed. So like we discussed, we have our rapid acting, our short acting, our intermediate acting, long acting, and then ultra long acting. When we think about our rapid acting insulins, we think about Aspart, Lispro, or also glulisine. So Aspart is also known as Novolog, and then Lispro is also known as Humalog. Glulisine is also known as Apidra. So duration of effect, usually for your Aspart, the effect is about 15 minutes. You get a peak of 1 hour. It lasts about 3 to 4 hours for all of these. So once again, for your rapid acting, effect is within 15 minutes, peak is 1 hour, and duration is 3 to 4 hours. And for short acting, we have our regular insulin. Regular insulin is only IV insulin. Its effect is in 30 minutes. It peaks between 2 to 3 hours, and it lasts for about 5 to 8 hours. Intermediate acting, we have our NPH. Effect is between 1 to 2 hours, peak is at 4 hours, and it lasts about 16 to 24 hours. And then you have glargine, also known as Lantus, and detamere, also known as levemir. These are going to be your long-acting. Usually the effect is between 1 to 2 hours. Duration is 24 hours for your Lantus, and then for your detamere, duration is 20 hours. And then you have your ultra-long-acting. This is going to be your degludec or your depot injection. Effect is between 1 to 2 hours. Peak is none, and duration is about 48 hours. Side effects in general of insulin are going to be hypoglycemia, by far the most common one. It can also cause lipodystrophy, which is obvious, right? Because due to repeated injections in the same site. So that's why you tell your patients to make sure that they're rotating site whenever they're injecting their insulin. Weight gain, hypokalemia. So with these patients, if they are in moderate hypoglycemia, right, usually if it's a mild, you can do something like orange juice or give them a sugary snack. If it's moderate, you're going to do intramuscular glucagon. If it's severe, you're going to give them IV glucose. We think about D50, right? All right, next one's going to be your hyperthyroidism medications. We think about our classes. So we have our thioamides. These are going to be your first class. We think about methimazole and PTU. Usually for hyperthyroidism, first line is going to be methimazole. The mechanism of action for methimazole is going to be decreased thyroid hormone production by interfering with your TPO. And then for PTU, you're going to have decreased peripheral conversion of T4 to T3. So the adverse effect for the thioamides is going to be bone marrow suppression. They really like to test that. Agranulocytosis, also aplastic anemia. So it's really important that if you suspect agranulocytosis and or anemia, you want to check a CBC. Other side effects for methimazole, just for methimazole, is going to be fetotoxic. So that's why with these patients, you avoid them in pregnancy, right? And that's why you choose PTU over methimazole in pregnancy. So for PTU, you're going to use in patients who are pregnant and or breastfeeding, but the black box warning is that it causes hepatotoxicity. Beta blockers, we think about propranolol, metoprolol for patients with hyperthyroidism that are having the tachycardias. So what it causes is that it increases adrenergic tone. Iodine also is used for hyperthyroidism. It blocks release of thyroid hormones. And then steroids, it reduces T4 to T3 conversion. Hypothyroidism, we have levothyroxine and triiodothyronine. So I apologize if I butchered these. Levothyroxine, also known as Synthroid, and then triiodothyronine, also known as T3. Mechanism of action is that there's synthetic T4, so they cause thyroid hormone activity. Usually levothyroxine is going to be the first line for hypothyroidism, right? Usually side effects for these drugs are going to be rare, unless of course the patient overdoses, so they can get thyroid toxicosis, cardiotoxicity, increased sympathetic activity, insomnia, anxiety, right? Especially if they overdose. Contraindications for your for levothyroxine and your T3 is going to be if they had a recent myocardial infarction, thyroid toxicosis, adrenal insufficiency. And it's important that these patients take these medications on an empty stomach 1 hour before their meal. Okay? All right, what about drugs for your hypothalamic and pituitary disorders? So we think about desmopressin. This is going to be a synthetic ADH or DDAVP. This is usually given for central diabetes insipidus or von Willebrand's disease, right? Adverse effects, it causes hyponatremia. We also have octreotide. This is a somatostatin analog. It inhibits growth hormone. It's used for acromegaly and gigantism. It's also used for esophageal varices. I used it a lot when I was in the transplant ICU with our patients that were cirrhotics. Adverse effects are going to be abdominal pain, nausea, vomiting, and diarrhea. We also have cabergoline or bromocriptine. These are dopamine agonists. These inhibit prolactin release. They are used for prolactinomas, acromegaly, and the adverse effect is going to be hypotension. Glucocorticoids is going to be the next drugs. These are essentially replacements of cortisol from the adrenals. They cause a broad immunosuppressive effect. They decrease leukotrienes and prostaglandins. You can give them systemic or topical. We think about systemic glucocorticoids such as prednisone, dexamethasone, hydrocortisone, and methylprednisolone. Our topical ones are going to be triamcinolone, hydrocortisone, clobetasol, and betamethasone. You can also do fluticasone and budenoside. These are usually going to be your inhaled steroids. These are usually used for any type of inflammatory process, immunosuppression, cancer, chemotherapy, Addison's disease, and asthma. We think about our inhaled ones, right, for asthma. Adverse effects for glucocorticoids is that they can cause hyperglycemia like diabetes, osteoporosis, vertebral fractures due to bone loss, Cushing's syndrome, acute pancreatitis, and then also poor wound healing. Okay. Next one I want to go into is going to be your type 2 diabetic medications. So we have our bigonides, also known as your metformin. We said that's going to be the first line treatment, right? Aside from lifestyle changes, it's going to be metformin. Mechanism of action is that it decreases hepatic gluconeogenesis. You have to know this. I can guarantee you're going to get this on your exam. So metformin decreases your hepatic gluconeogenesis. The good thing about metformin, why it's first line, is that it doesn't really cause hypoglycemia. Next one is going to be your sulfonylureas. We think about glyburide and glipizide. These increase insulin secretion, but these are known for causing hypoglycemia. You also have your meglitinides. So we think about repaglinide and netaglinide, just like how they sound. They increase insulin secretion, and these are known for causing hypoglycemia. You have your thiazolidinediones. These are your pioglitazone and your rosiglitazone. These increase insulin sensitivity in muscle and fat, and these are also known for not causing hypoglycemia. You also have your DPP4 inhibitors, your sitagliptin and your saxagliptin. These increase insulin secretion, and these are safe for not causing hypoglycemia. You have your glucagon-like peptide 1 agonists, also known as your exenatide, your lexacenatide, your liraglutide, and your dulaglutide. These increase insulin secretion and decrease glucagon secretion. These do not cause hypoglycemia. And then you have your gliflozones. So anything that ends in gliflozin. So you have your dapagliflozin, your canagliflozin, and pagliflozin. This one reduces reabsorption of filtered glucose in the proximal renal tubules, resulting in increased urinary excretion of glucose and reducing plasma glucose, and these do not cause hypoglycemia. So like I said, the ones that you do need to know is going to be metformin. This decreases hepatic gluconeogenesis and is known for not causing hypoglycemia. All right, guys, I hope this video was helpful for those of you who are studying for your PANCE exam. I have a link below that has other topics that are covered on the PANCE. My plan is to hopefully cover all the topics, but so far I've done cardiology, GI, pulmonary, dermatology, and then also neurology, and then this one's endocrine. So keep on looking at my page and watch out for those YouTube videos for upcoming videos for the PANCE review. Also, if I did any mistakes, please comment below and let me know. Also, if you have any feedback for me in regards to how I can better improve these videos for you guys, please let me know. All right, as always, take care. Pass your PANCE, you got this, and it's all about repetition, so repeat, repeat, repeat. That's how you're going to pass your exam, and that's how I passed my PANCE exam. All right, talk to you guys later.